Ladies and gentlemen, once again, we are here for another edition of the Cameroon Town Hall for Healthcare Professionals. This is a platform that brings together healthcare professionals from Cameroon who are spread across the globe. We have had many editions, I think counting to 29 or 30th edition. Alison, are we on the 29 or the 30th edition?
Good question, Elvis. I guess at some point we really just stopped counting. We're just going on and on. It's been such a pleasurable ride that we just stopped keeping track of time.
Thank you so much. And last week we were here again and we had a very interesting conversation on customer care in the healthcare sector in Cameroon. This was a conversation and it was really interesting. We came up with very salient ideas on how we can solve this problem. But first, we wanted to identify why there is this problem. And we heard from one of our members of the town hall that people can be groomed to empathize. So you're not born with empathy, so you can be groomed to empathize. And with this notion, we all agreed that customer care can be included in the curriculum and really emphasized upon so people can be taught to actually show empathy to their patient, and that employers can actually put in place a feedback mechanism or system where where patients can actually give their feedback on how they were treated, and that they could also be a public system of naming and shaming those whose attitudes are actually outrageously bad. And so we had all these kinds of ideas, but there was something that stood out from that conversation. One of us who is a medical doctor had a testimony of how when she was in labor, a nurse told her that, "Wow, see, doctor, even you, feeling pain, I thought doctors should understand." But of course, pain is natural. Everyone feels pain. Sometimes doctors even have open nerves. They feel pains more than every other person. And so because pain was one of those areas that is being ignored by healthcare professionals, and that is when somebody is in pain that you are expected to show professionalism and empathy. I mean, a month ago, we had a conversation here about sickle cell disease, and yet one of us, a doctor from Germany, who is a Cameroonian, gave a testimony how as a sickler in Cameroon, he would not want to go to hospital during sickle cell crisis because the pain management was poor, and each time he was in pain, he was being perceived as pretending. So pain is a very serious issue. And if we cannot manage pain well, then there is no way we can ever show empathy, because somebody who is in pain does not care how much you know, but just want to know how much you care. Once again, we are here today and we shall be talking about pain management during labor and delivery, a very interesting topic with a real top expert in this field. But of course, before we start, Alison, what do you have to say about this topic?
Oh, this is a topic that touches home for me. I don't have kids yet, but I do tell you, Elvis, the day I get kids, I don't want any iota of pain felt. Like it's a very a sensitive topic for a lot of women in the Cameroonian setting, and not just the Cameroonian setting, the African setting as a whole, because there's this perceived perception that if a woman has not felt pain during labor, then she hasn't given birth, then she's not woman enough, then she's not African enough. Is it really truly the case? I remember putting up this poster, and a few friends and other women that I haven't even met reached out to me, and they're like, "Alison, thank you so much for bringing up this topic." Elvis, one of these days, I'm hoping that with all the innovations in science, that would have a machine that can transfer some of the pain that we feel to our men and to our brothers. So you guys can have a pinch of what it feels.
Back to sender. Well, that would be challenging because again,
yeah. So thank you really, Edwin and Venasius, for agreeing to join us today on this platform to talk about this topic. And know that even if we don't have lots of women who maybe are not able to join the Zoom call, are listening to you on our various platforms and are very keen to hear what you have to say about this topic. And I'm also excited because we have some of our colleagues who've had to work home, like Raymond on the platform, who could be able to tell us what's happening home. My sister told me, "Alison, when it comes to give birth, when my time to give birth comes, I hear Hôpital Général Douala will charge me 400,000 francs CFA for, anesthesia during labor. Is it truly the case?" So we're here to hear our experts enlighten us on all these key topics and all these sensitive issues. And to all of you joining us in the town hall, I hope you're well. I hope your families are well. It's always a pleasure to see you. Elvis, over to you.
Thank you very much, Alison. Thank you. And you best know that men have very little pain threshold. So if you transfer that thing to us, we are gone. So thank you so much for, highlighting the importance of this topic. And of course, we are here thanks to our chairperson, Dr. Mono Kenneth, who has always been working so hard on the backstage to put all that is necessary for us to have this kind of session. So we will always start with updates on COVID-19. And now over to you, Chair.
Elvis, thank you very much. Today I'll try to be as brief as possible because I'm also very, very interested in this topic. My mother being a midwife, I got to, in my early age, see a lot of young and vibrant ladies come to the house when they were pregnant and rushing my mom to the hospital. So it's a topic that actually drew me to medicine. So it's very interesting to get to see what we can offer in order to make quality of life better for women. So today I'm just going to talk about, we're having issues with vaccination, even in the US and in the world. There's still issues with vaccine hesitancy. There are other issues with the Delta variant. We don't know exactly what's happening, if this variant is truly going to be a game changer in terms of if our vaccines are going to work. We're having surges that are occurring in different parts of the world. I'm just still worried about Africa. Indonesia has taken over India. And we're also seeing new cases popping up in England. England in particular had a record number of cases yesterday. So we're seeing surge in cases. And we still remember this was some presentation I did some past, almost a year ago, talking about the different strategies. We got a vaccine, which we're not expecting, but we should not forget that masks do work. And in science, there is nothing that has occurred in science that is as great as what we have gone through in the past 1 year, developing a vaccine against coronavirus. We are not done beating the pandemic, so there are still other things we have to do. The world has had almost about 200 million cases of coronavirus, and we're vaccinated almost about 3.5 billion people. So this is no longer a trial. We have given this to 3.5 billion people. Those who are vaccine hesitant should know that. And maybe very soon will be time for booster doses. Here is just a map on how countries that have been affected, and you see mainland China has not been affected. What do they do, which is different from what others do, is that they are still putting on masks. And it's important for us to know that their prevention is still very important. And here is the burden of the disease. And you see countries that have been affected the most: the US, Brazil, India, and most of Western Europe, and also Russia. So you see here, we have the number of cases that we've had all over the world. We have almost 200 million cases of coronavirus. If you had told a health expert this, let's say 2 years back, no one would have believed you, especially those in the US. Now we see the number of cases are actually rising. Israel had done a great job. So this is showing us that our vaccines are either wearing out and we may need booster doses, or the variant is escaping. But the good news is that we still see efficacy towards the variant, and we're seeing some surges in the United Kingdom, in Cyprus, and many other countries in the world. So here is Indonesia and the surge, which is the 4th largest country in the world. So we're going to see a lot of cases and a lot of death. Cameroon is actually, the cases in Cameroon are slowing down. This is time for us to get our vaccines to the people and get them vaccinated, so that once we have a surge, we are not going to be able to have a number of cases and a number of deaths. So I think I did get my family members vaccinated. I'm talking to some of them to go get the vaccines. They are available in Cameroon, and that's what is good. We have several vaccines. I think we have 4 vaccines available now. There is the AstraZeneca, there's the Sinopharm vaccine, there is also the Sputnik, and you do have the Johnson & Johnson. Number of cases are actually reducing. The number of deaths from COVID in Cameroon have stabilized. South Africa, which used to be the pivot point of COVID in Africa, the number of cases are reducing. And the US is still having fewer cases now compared, but the cases are rising. And here you can see the difference between 2 months. Just as the Delta variant came in, we're starting to have increase in number of cases. And these cases are being driven by those who are not vaccinated. Even those who are vaccinated get sick, but they don't die. But 80% of those who are in the hospital are unvaccinated people. We have had 3.4 billion doses that have been given worldwide. And there is still some discrepancy between the richest countries and the poor countries. Most of those who are vaccinated people are those who are rich. And we need to be able to fight the uneven access to vaccination worldwide. And when is life going to return to normal? I think life is going to return to normal once we realize that we need to vaccinate people and also continue with other measures. And I think it's wrong for us to stop wearing masks as quickly as possible. People need to know that this is part of it till we get a fixed solution for all of this. So Several countries with their different vaccination rate would take several months or years to get to vaccinate all their people. I think Europe, with the same rate they're going into, they'll be able to get herd immunity in 2 months, the US in 9 months, Israel in 12 months at the moment. They were the leaders, Cameroon in 10 years. You can imagine if we continue at this rate, in 10 years, we'll not be able to prevent the pandemic from spreading in Cameroon. And are we doing anything to stop the pandemic? Yes, we are in some places, in other places, no. So it's very important for us to know that we need to fight this vaccine. The top vaccinated countries in the world, there is no African country among the first 20. So this is sad. And we do have several vaccine candidates that are available. Some of them are cheap, accessible. WHO is doing everything to make them affordable for African countries. We can see these are the different variants that exist right now, the Delta variant, and there is also a new variant, which is the Gamma variant, which is from Chile, South America, and also the rate of transmissibility is also extremely high. I think we'll get updates on that variant as soon as possible. The Delta variant is almost taking over the pandemic in the UK and also in the US. And here you can see the comparison between the variants and the transmission of measles and mumps, with measles being the most transmissible disease we know about so far. The duration of immunity, we know it lasts, right now we have information that it lasts for about 8 months, but we may need booster doses, though the CDC said they're still working on deciding if we're going to need it. And also we may need to tweak the vaccine a bit in order to cover this new variants that are popping out. So here you have the data showing the efficacy of the different variants in terms of the different vaccines we have with Pfizer, Moderna, AstraZeneca. You also have the BioNTech and the J&J. So we do know that the biggest challenge coming forward is going to be the Delta variant, which is about 1,000 times more, has a higher viral load compared to the regular variants that we had. And we do know that vaccines do induce immune response, even in the variants, and some vaccines are better than others, but that's a topic for another day. So here, those who want to have my slides, you would get to see that they are different. This is just a summary of the different vaccines we have. And the Moderna, to get to know, if you want to educate, use this for educational purposes. The Novavax is being reviewed now by the FDA for approval. And we do have all the vaccines here. In terms of treatment, there have been very little or no improvement in treatments since the last time I did do a presentation. We do know monoclonal antibodies do work. This is a slide just summarizing the different monoclonal antibodies, and I think they're very efficacious. We also do know that Regeneron is one of the best that is out there, and it works very well. In terms of treatments and therapeutic supportive care is just the best thing that we have out there right now. Remdesivir reduces length of stay in the hospital. Corticosteroids have been shown, especially dexamethasone, that it actually does reduce mortality. That's one of the few drugs that have been shown that it reduces mortality. There are other things like azithromycin that we've been using, which did not show any form of improvement in patients who had COVID. We also did see that tocilizumab, which was initially tested in the US, has been shown in the recovery trial that it works. Baricitinib also does work. And, but the key to all of this is not therapeutics. Hydroxychloroquine, there were several trials that did show that it did not work, both outpatient, inpatient, and prophylaxis. Convalescent plasma does work, but needs difficult to administer and difficult to control. So based on all this information here, I just want to say therapeutics is still a long way to go. Prevention is the best way for us to go forward. We do have monoclonal antibodies that we do give to patients who are not severely sick. And ivermectin is still a debate that is going on in the scientific world, but majority of those people believe that it doesn't work that much. There is an East versus West divide in the US in terms of ivermectin, and colchicine also works in the outpatient department, and you do have some antipsychiatric medications that are showing some promises. Vitamin D actually helps in preventing people from getting very sick, but administering vitamin D does not reduce mortality based on the studies that we have so far. So based on all of this, Elvis, I don't want to waste much time, and I would give more updates coming next week. Thank you. Our presenters this topic is dear to me, and I really want to hear them go back to this topic. So thank you very much, Elvis.
Thank you very much, Mono, for putting updates on COVID-19. We know, and everybody in the town hall knows that if you've not heard anything about COVID-19 in 2 weeks, be sure that when you come to the town hall, you are going to get all that you are supposed to know. So don't bother reading about COVID-19 updates because Mono is there to digest it for you and make it simple in every fortnight. Thank you so much. And we have been joined by one of our co-moderators, Dr. Brian Tegomo, who is already here with us. Brian, hello.
Hi, Elvis. It's really good to be back. And thanks a lot, Dr. Mono, for that very up-to-date point on what's going on in the COVID space around the world. Really thrilled to be back and looking forward to hearing the remarks of Dr. Aroke and Dr. Ngong on this very important subject on pain management, particularly in our context in Cameroon and in Africa. So I'm really looking forward to their feedback, their remarks. Thanks.
Thank you very much. And everyone is excited to hear from Dr. Aroke and from Dr. Venasius. These are all trusted authorities in the field of anesthesiology and all pain experts. And I think if you want to hear the best way in which we can actually manage pain in the labor and delivery unit of our hospital, then today is your day. We also have other experts like Raymond, who is here with us and who has practiced also in Cameroon, and he's also a trusted authority in the field. I know from time to time, he is going to chime in to add his own voice to this conversation. But before we give the floor to them, Alison, can we know who these people are?
Sure. You know, I felt very, I found myself in a very difficult situation because we have our presenters who are experts, but who are at the same time, very modest people. And so we asked them, what would you want us to tell the people about you? And then they send us very small things. I just want the audience to know that this presentation, even that we make of our presenters, it really doesn't tell a full story of who they truly are. It just gives you a tip of the iceberg. It gives you insights into the amazing work that they are doing in their field. So we might just read a few sentences because they are very modest people and they really want us to dive into the scientific aspect of it. But these bios do not tell anything about the quality of people that you have in front of you today. So I'm going to begin with Dr. Aroke, who recently was in the news. For those of you who don't know, he put us on the map. He made us proud, for several awards that he got this year. So Dr. Edwin Aroke earned his Bachelor of Science degree in biochemistry from the University of Buea before moving to the United States. He graduated from Duke University Nurse Anesthesia Program, and while practicing as a certified registered nurse anesthetist at the University of Massachusetts, he earned his PhD from the University of Massachusetts Medical School. In 2017, he joined the faculty at the University of Alabama in Birmingham. The NIH currently funds Dr. Aroke's research that examines the role of epigenomic changes on chronic pain and pain disparities. He has received multiple recognitions, including Health Disparities Research Institute Scholar by the NIH, Didactic Faculty of the Year by the AANA, and the Researcher of the Year by the AANA Foundation. Additionally, he's currently the president of the Association of Cameroonian Nurse Anesthetists in America. Dr. Aroke is a professor, an assistant professor with the University of Alabama at Birmingham. So everyone, please just join me, say hello to Dr. Aroke and to welcome him to the town hall. Dr. Aroke, it's such a pleasure to have you with us. And we look forward to hearing a lot more about your work and about the person that you are. I'm now going to go ahead and present to you Dr. Ngong Venasius, who is a brother. I've known Venasius for a while now, and trust me, when it comes to all your pain issues, Venasius is the person to go to. So Venasius earned his Bachelor of Science in Microbiology and Medical Laboratory Technology from the University of Buea in 2005. And he earned a Bachelor of Science in Nursing from the Grambling State University in Louisiana in 2010. He then went ahead to train as a doctor of nursing practice with focus in anesthesia, and he graduated from Louisiana State University in 2018. He currently works as the chief of anesthesia at Garrett Regional Medical Center in Oakland, Maryland. And in terms of awards, he has also received numerous awards, and I'm just going to mention a few. He was the Somnia Anesthesia Student of the Year 2018 in the United States. He received the Stanley Hall MD PhD Award for Academic and Clinical Excellence and he got the Sheridan NEH Scholarship Award for exemplary clinical and leadership skills at the national level. So Dr. Venantius Ngong, it's a pleasure to have you and welcome to you as well. So I'm going to hand the floor back over to our speakers so they can take it over from here.
All right.
So we are going to start the presentation by listening to Dr. Edwin, who is going to start the presentation.
All right. Thank you, everybody. I hope you can see my slide clearly. And thank you, Alison, for that great introduction. And, you know, like they mentioned, if you notice the subtitle here, it says, you know, what every adult should know. And that is really my goal here, is to really bring to light, you know, some of the current therapeutics that we have, you know, that we all can do, may make a difference. You know, both the parturian, you know, the nurse, the spouse, we all can make a difference to, you know, improving how patients are cared for when having labor and delivery. So in terms of objectives, you know, I hope that, you know, we just highlight a little bit of some of the anatomy of labor pain and basically say, why does this pain happen? Then we'll talk a little bit about why should we worry about it, you know, because if you have heard anything from laboring mothers back home, you will realize that it's partly, you know, a myth, or so partly equally our culture that this is expected. But what we fail to understand is unrelieved pain has its own effect. They will equally understand some of the traditional approaches to labor pain management, and then look at some alternatives for those who do not prefer pharmacological interventions. So, you know, in Cameroon today, we always start most things with the Bible, right? Everything starts from the Bible, and most of us in Cameroon are Christian. And what does the Bible say about labor pain, right? It recognizes that it's a big problem. You know, it tells the woman, you know, I will make your pain in childbearing very severe. With painful labor, you will give birth to your children, right? And if this is recognized in the Bible that it's painful, then why is it that, you know, we are not doing anything about it? There's a lot we can do. And the field of, you know, pain management and obstetric anesthesia, you know, dates way back to the 1800s. And I feel ashamed to say this because if we think about it, that in 1847, Simpson is credited to really starting this movement where he described the use of diethyl ether, you know, for cesarean delivery. So back then in the, so to speak, dark ages, somebody recognized the need to achieve adequate analgesia, you know, during labor and delivery, specifically for cesarean section. Then if you fast forward to 1853, that is really when Queen Victoria requested, you know, analgesia for the delivery of Prince Leopold. So after that, it took off, you know, members of the public started requesting that, hey, we can equally have what the royals are having. You know, if the royals can have chloroform for pain, you know, for labor and delivery, why not me? You know, and as such, you know, there was a rapid uptake of chloroform. But fast forward again, now by 1874, it became apparent that yes, even though it was working, you know, chloroform became detected in the blood of neonates who were delivered and equal in the CSF. But even more important, it was linked to neonatal depression. As a result, from then, you saw the decrease in chloroform, but there was an uptake in the exploration of other methods. It became very clear that how can we better manage this pain? As a result, then you see from there the progression through things like scopolamine, you know, administration of opioids like morphine, then epidurals and spinals. And Dr. Ngong will talk quite a bit about, you know, the history of epidurals and spinals for labor and delivery. So this slide was just to really bring to light the fact that these concepts or these ideas are not new. These are not new innovative things we are talking about today. These are things which have been in the works for a long time. And I think that, you know, we can really think of how can we better manage pain for women undergoing, you know, labor and delivery. And just as a quick, you know, update, when we talk of pain, what is it, right? What is pain? And we all have experienced pain. We all will experience pain at some point in our life, right? And there are two main components when you think of pain. You have the sensory, the nociception, right? But you equally have the emotional part. And that emotional part really brings to light the individual aspects of pain, right? You cannot just think of nociception without thinking about the emotion associated with it. Pain is always a personal experience, right? That is something that is going to be very important for us to remember, right? It's what the patient says it is. Two people may have similar injury, but we have very different pain experiences. Your prior experience affects how much pain you perceive and report. Similarly, the person's report of an experience in pain should be respected. Because if I tell you this hurts so much, you may not necessarily see it. And that is the uniqueness of pain, the fact that even as providers, we do not necessarily see what the patient is saying. So the only way we can adequately manage pain is by believing them. And although pain usually serves an adaptive role, right? I don't want to disparage pain and say it's a bad thing. It keeps us alive. Without pain, we will all be dead, right? Pain tells us that there is danger here, stay out of trouble. So it's important that we recognize that it has value. However, again, left unchecked, pain can lead to several detrimental effects. So emotionally, we can each select some of our coping mechanisms, right? During labor and delivery, we always encourage women to take deep breaths, right? Breathe slowly, hyperventilate, think of the outcome, which is great. That is that emotional aspect. But what about the woman that comes in with pre-existing anxiety? What about the one that comes in with pre-existing depression, right? What are we doing for them? We can do better. So in terms of labor pain, like most types of pain, the experience of labor is complex as well and subjective. Right? Several factors are going to affect how a woman reports pain and how much pain they are going to experience to report with each labor. Even from one delivery to the next, they will experience different amount of pain. So just because during the last labor, they had very little pain and went natural with no pain medication, doesn't mean that in subsequent delivery, they may not need pain medications. So again, I want to emphasize that like pain or other types of pain, labor is an emotional experience. And I think this is really where the mistake comes in our thinking. Because if you were to ask most women, studies have shown that if you ask women 3 months after delivery, how bad was the pain? Because they were happy with the outcome, they are likely to tell you, it was okay, I can do it again, right? Because the ultimate outcome for them, which was most important, was having a baby, and a healthy baby, of course. So they tend to underestimate how much pain they experience, right? But if you really were to ask them during that delivery how much pain they're experiencing, you will realize that it's one of the most painful experiences every woman or any human can go through. Often described as cramping, sharp, aching, throbbing, pressing. There are just multiple ways of describing it. But again, it is important to remember it's different for each woman, and it can be different for each labor. So, really, really, that subjective view is important. But even more important is the fact that we have to believe them. So in thinking about labor, you can't really talk about pain without talking a little bit about labor. I wouldn't go much into this. I would let the OBGYNs tell us about the different stages of labor and how long it lasts. But conceptually, labor is typically broken down into 4 main stages, right? Stage 1 labor, beginning from when there is the onset of regular contractions, and ends with complete dilation of the cervix. Well, so what pain is usually associated with this? So if you think about, stage 1 labor, during the first stage of labor, pain results primarily from the uterus contracting, right? And the pulling on the cervix, which causes the effacement and the dilation. Pain intensity during this phase would progressively get worse with increased contractions, with the increased frequency of contractions and the increased dilation. Contractions can actually feel like aching in the lower back. Some women would describe it as intense menstrual cramps or the pressure and tightening of the cervix in the pelvic area. These contractions usually feel stronger and longer as the labor gets progressed, right? Specifically during the active phase of labor, right? That is when the pain relief is usually requested. Here in the US, as anesthetists, we usually make fun of it. We'll say, hey, when I meet a woman during stage 1 at 0 centimeters and I take concern for analgesia or epidural, most of the time they will tell you, no, I'm good. Then my response is always, okay, let's just sign it. While you still have things under control, while you are still thinking straight, let's talk about it. Let's discuss what are your options. Let's talk about what you want and not want. You give me consent in case later you change your mind. Then typically around 7 centimeters is when the pain really gets unbearable. Unfortunately, that usually coincides equally with the time when oral and IV medications generally do not work well. Now, stage 2 begins with complete cervical dilation and ends with the delivery of the baby. That is a great news, right? That is really when everybody is happy. That is the outcome we want. But if you think about it from the pain perspective, during the second stage of labor, really pain is caused by the descent of the baby, right, through the cervix into the vagina. Many women would describe pain as pressure at this point, and they usually, interestingly, will welcome the opportunity to be active in the process. The fact that they have the urge to push and can actually help in facilitating that movement gives some satisfaction. Pain at this point is very intense, much more painful, but that participation, that active participation in the process enables pain analgesia to be achieved much easily. So it's a very interesting paradox that they're experiencing way more pain, but the fact that they can do something about it, the fact that they can facilitate it by pushing, really makes it such that the women feel more satisfied. So at this stage, if you are to administer any medications, chances are you probably will not have great analgesic relief. This is really the stage when, if you have an epidural, great, that will work very well. However, it's a stage equally when you do not want to dose it such that the woman doesn't feel anything, because feeling that pressure and coordinating with that pressure is going to be essential for a successful delivery. So it's an interesting paradox to really do it. Post-delivery, you get into stage 3, which begins immediately from the delivery of the baby to placenta delivery. And usually by this time, pain is gone. Everybody is happy. They're giving high fives, smiling. The woman typically, has mixed emotions. The emotions of all the catecholamines which are circulating in her body, but now equally the satisfaction of having the baby. And that takes us to stage 4, which is usually stabilization. So again, in just thinking about that pain, so you cannot really talk about pain without talking a little bit about pain pathways. And I will not go too much into the details of it, but labor pain, usually we divide that into 2 main components. You talk about visceral pain and somatic pain. If you think of visceral pain, the visceral labor pain occurs during the first 2 stages. Again, when I said pain was most intense, with each uterine contraction, the pressure is transmitted to the cervix, causing the stretching and distension and activating excitatory nociceptive efferent neurons. These efferents are transmitted through small unmyelinated C fibers, which travel through the sympathetic chain and pass through the uterus to through the uterine wall and the hypogastric nerve plexus. Interestingly, like most pain, of course, when it gets into the spinal cord, it crosses before ascending, through the spinothalamic tract to the higher centers of the brain for interpretation. Where does it enter the spinal cord? It enters through T10 to L1 or L2 spinal nerves. So this is going to be very important when you start thinking about epidurals, which Dr. Ngong will talk about, right? This is why epidurals are very effective during the first 2 stages of labor, because if you can effectively administer an epidural to block this band of nerves, then you are really blocking that visceral pain. Now, what about somatic pain? You tend to see somatic pain towards the end of phase 1 into stage 2, right? That is when you see somatic pain, and it arises again from efferents that innervate the walls of the vagina, right? And that really results from the stretching and distension, partly equally because of a little bit of the injury taking place and ischemia that is taking place, right? Unlike visceral pain, which is transmitted through your C fibers. Somatic pain is transmitted primarily through small myelinated A delta fibers. These fibers give you much more precise pain, sharp, precise pain. So that is another slight difference where, unlike visceral pain where it's dull, the real cannot tell you where the pain is, it's vague, which contributes to why providers will think, well, is it really pain? Where you say, where does it hurt the most? And then they say, it's everywhere, right? You want them to tell you specifically where it is, but by the nature of it and the fact that there is crossover in the spinal cord, visceral pain is very dull and not easily localized. When it gets to somatic pain, the pressure is very localized because it's transmitted by A delta fibers, which are much more specific. And the woman can specifically tell you, I have a lot of pressure. That is really when they have the urge to bear down and the urge to push, right? So they typically will report a lot of pressure in the rectum and the vaginal area. And this pain is transmitted through down in the sacral area, the S2 to S4 region. So what will really help at this point will be a nice, caudal block or a very intense block to the pudendal nerve way down here in the rectal area. So in terms of, again, just looking at the pain pathways, if you were to look at it, again, just another view of it, visceral pain, we're thinking of it from T10 to L1, right? Somatic pain, sacral root. So you're thinking of a paracervical block, a pudendal nerve block. Again, each time we can block transmission through the nerves, right? We can block that nociceptive. That is a sensory aspect of it, right? It's not taking care of the emotional aspect, but at least it's taking care of the sensory part of it. So why should we worry, right? Again, this is really what it comes down to as providers, because when you think about pain, you have to believe the provider. So most of the time, when I give talks about pain here in the US, I tell people, so imagine when we were back in Cameroon, right? If somebody asks you how cold something was, the only reference we had was a refrigerator, right? You said, oh, is it as cold as the refrigerator or the freezer, right? That was our reference of coldness. But we never realized that something could be colder than that. Now that we've come to the US and we've experienced the winter vortex, right? Now you know that now a -4, a 4-degree cold is really not that cold, right? And that is the same thing with pain, because each time a woman reports that she is in pain, as a provider, we have to take that information, process it, and decide whether we believe them or not. Do we believe that they are in much pain or not? If we do not believe them, we will not do anything about it. If we believe them, we will intervene, okay? So if you're taking nothing from this lecture, I would say, why should we worry about it? Because it's the right thing to do. It is the morally right thing to do. We want to alleviate pain. That is why most of us went into healthcare. Most, illnesses manifest in the form of pain. So why not, take care of, the greatest pain out there? Not only that, pain is really a big deal because, again, what happens during labor and delivery? So let's take a look at generally. Most of the time, I will start on this side. Most of the time, to manage with the pain, right, we'll tell the lady to hyperventilate. Most of them are breathing faster, partly from the stress, but partly from what we tell them how to cope with it, right? So that hyperventilation results in respiratory alkalosis and hypocapnia. Well, unfortunately, as we know from our physiology, when you have hypocapnia, it leads to the leftward shift of the oxygen dissociation curve. That decreases oxygen transfer to the fetus. So the same reason why most people do not want to give medication, because they say they do not want to affect the fetus. Well, I have news for you. When you do not relieve the pain, you might as well equally be reducing oxygen transfer to that fetus you are trying to protect. What happens equally with increased maternal stress and is when you have increased maternal stress, you have the release of catecholamines and cortisol, the stress hormones, right? Well, that alone is increasing oxygen consumption in the parturia. Then you have, with the increasing levels of circulating catecholamines, you have increased uterine contraction. Each time the uterus is contracting, what's going to happen? you have increased uterine vasoconstriction. Each time you have vasoconstriction, it means you have less blood flow. Now, when you have less blood flow, you have the building of other end products within the muscle, because the uterus is just a muscle like every other muscle. You equally have decrease in uterine contraction, because now you have less blood flow to the uterus itself. You have decrease in placenta blood flow, and overall you have a decrease in the oxygen delivery to the fetus, which can equally result in fetal metabolic acidosis. Okay, so uncontrolled pain can actually really hurt the fetus that we are trying to protect by saying, let's not give medications because it's going to go and accumulate and make them sleepy. Okay, besides these physiologic effects, you equally have psychological effects. Think about the woman. Again, most of the time when you think about it, 3 months later, we all develop amnesia from it and say, oh, it's great, I have a healthy baby, I'm happy. But unrelieved pain has long-term psychological effects. If you talk to close friends, you'll probably be hard-pressed to find that there are many women who haven't had second or third babies because they don't want to go through that pain again. They tell you the pain was so intense, I don't want to experience it. We all know about depression. That is a big deal, right? If a depressed mother cannot take care of the baby, unrelieved pain can lead to anxiety, depression, severe COPD, phobias, and sexual problems. For the guys present, this is a big deal, right? Having a lady who has sexual problems is a big deal for the guy. So if for anything, guys, please pay attention. Make sure that your woman is having adequate analgesia. Even for the partners, they may equally experience feelings of guilt and helplessness. This may not be so much the case back in Cameroon where, again, I may be dated in this, but from my experience back home, I do not practice that, but from what stories we heard, while the woman is struggling with the delivery, the man is at the bar somewhere with the friends waiting for the good news to pass around, right? Well, here in the US, men are typically present in their room during labor and delivery. And that presence of the spouse can create a sense of helplessness, where you see somebody you love and care so much going through agony, yet you cannot do anything about it. It has equally been associated with phobias and depression. So again, it has long-standing psychological effects beyond what we can immediately see. So finally, this is my last slide to give you why we should really care, right? So think about it. So in this study, they were looking at chronic pain syndromes. This is basically looking at labor pain and then accidental, injury. And I say, just imagine for a minute that you went to a doctor, because during labor and delivery, we are present. You went to your surgeon and he said, well, hey, we have to do a digit amputation, but sorry, there will be no analgesia and there will be no anesthesia for you. You just have to toughen through it. It's what everybody does, right? After all, during accidents, when you have an accident and your digit is amputated on the road, we don't usually give anything out on the road. We all would think that is absurd. But in reality, when you look at pain intensity in a nulliparous woman, right, a woman having a baby for the first time who did not have any prenatal training, the pain of labor is only comparable to that. That is how intense that pain is, right? It's comparable to having a digit amputated without analgesia. If you think about things like chronic pain, non-terminal cancer pain, phantom limb pain, arthritis, toothache, if you've had a toothache, you can appreciate this, right? The pain of labor far exceeds that. Even for a woman who is trained and haven't had babies before, a multiparous parturient. Okay, so it's a big deal. It's way more painful than having a bruise, a cut, a laceration, or a sprain. And again, would we tell our patients that, sorry, you just had this major fracture, we won't give you any pain medications for it? Or would we say, hey, at least there is some paracetamol here for you? So again, if you do not take anything from this, remember, it is intense pain. It's not just a little bit of pain. So when I thought I was going to give this lecture, I decided to post on Facebook and ask women from Cameroon, what do you think? Share your experiences. And these are just two of what they said. One said, please, I don't even want to think about that day again. I cried like a baby because I could not take it again. Okay. Another said, hey, did you just say pain management? There is nothing like that here. I gave birth 2 weeks ago in Limbe and the pain was hell. I mean, real hell. They don't even give anything to manage pain. I felt it raw. In fact, something really has to be done about it. This is what women in Cameroon are saying about it firsthand. Okay, and as providers, I think we can really do something about it. There is, again, we saw that from the 1800s, people were doing something about it. So I think it's something we can definitely do. This is the only slide I have on neuraxia. This is the gold standard, right, for labor and delivery. Having an epidural is a gold standard to manage that pain. On the downside is it requires a skilled provider, right? A trained personnel, there are occasional failures, but it gives complete analgesia, right? Complete analgesia, no maternal sedation. You are not administering generally medications that which will affect the baby. Again, I would let Dr. Ngong speak more on the epidurals later, but I just wanted to bring that to your attention that when you start thinking about what we can do, this is the gold standard. What about IV medications or IM medications? We have a lot in our formulary already in Cameroon, right? There is so much, we have a lot of medications we can use today. The key to remember is nearly all IV opioid medications and sedatives readily cross the placenta. That is true. They will cross the placenta and they may affect the baby. So it's important, therefore, to really think about each medication individually, think about what effects we can tolerate and which effects we cannot tolerate, right? CNS depression affects the neonate and it can manifest in the form of respiratory depression, respiratory acidosis, it can affect fetal heart rate variability. But most important to remember is the fact that if you have a premature fetus, they are going to be way much more sensitive to your opioids and sedatives than a fully developed fetus. Opioids, by their very nature, would equally precipitate maternal respiratory depression. Unfortunately, some of the side effects of opioids include things like nausea, vomiting, and delayed gastric emptying, which are already present, right, during labor and delivery. But the degree of any side effect that you will see really depends on the specific medication that you choose to administer, right? The dosage and the time that has elapsed since that administration to delivery. So it's going to be very important for us to pay attention to those things. So I'm sorry, this is a little busy slide, but it gives you a summary of some of what is available. So take, for instance, Demerol or meperidine. I mean, if you think of parenteral medications, it is the most commonly used opioid worldwide for labor and delivery, hands down. The interesting thing about it is that over the last several years, there have been multiple studies looking at its true analgesic efficacy, right? And the concern that it can potentiate, both maternal and fetal depression, which is true. But the beauty of using meperidine is, one, it's readily available across multiple settings, right? It's available everywhere. Even in Cameroon, we have it in our formularies in most hospitals, but equally, it's relatively cheap. So as a result, we can readily use it. When administered IV, you would see the maximum fetal respiratory depression generally about 10 to 20 minutes after administration. So the unfortunate thing is that the fetal half-life is way much longer than maternal half-life for most of the medications. So if you are going to administer meperidine, it is best to give it at least 4 hours before the expected delivery, so that you've had time to start metabolism and the fetus equally has had time to start metabolizing it, so that most of the drug will be gone and you will see less fetal depression. Tramadol can equally be given. It's a weak opioid, relatively. Again, just like meperidine, you might want to give it sooner than later, just to give more time for it to be metabolized. The good thing with tramadol is you can combine it with paracetamol, and that is going to give you, augment that analgesic effect. Fentanyl, here in the US is picking up steam, especially fentanyl and remifentanil. These are highly potent short-acting and opioids, right? The good thing with them is maternal depression, generally, the analgesic effect generally will last very relatively shorter compared to the respiratory depression that you see. However, at very low dosages, when you administer fentanyl or remifentanil, you see very little or no fetal respiratory depression, right? So you have great analgesia with very limited respiratory depression. Morphine has been used extensively, but it readily crosses the placenta. So it's really falling out of favor. I would say it's one of those that you hardly see administered these days anymore because, again, of the severe maternal sedation that is associated with the administration of morphine. Nuben and Stardol, these are your agonist antagonists. They are relatively effective and they are frequently used. The benefit is they do not cause respiratory depression, right? So you are giving a medication that, yes, the analgesic effect isn't great, but it's better than nothing, right? And it doesn't cause the respiratory depression that we are worried about and the sedation. However, with Nuben, especially if you administer repeated dosages, you run into the risk of seeing some maternal sedation. I have added, promethazine and hydroxyzine here. Again, they can alone, you can either administer them alone or administer them with meperidine. Both of them will help reduce anxiety, right? Remember, most of the time, even in chronic pain patients, we see this. People tend to attribute that the woman's pain is because she's just thinking about it. It's all in their head. It's not real, right? Which is why that nurse probably made the comment to the physician last week that, hey, even you too, because they do not believe it. But hey, if you administer one of these, they're going to help reduce the anxiety. They can equally help reduce the nausea and vomiting. So they are great agents to add when trying to manage the pain. Paracetamol is available. We can administer that. It helps. Ketamine at low dosages, you will see that it's readily available in Cameroon. If you give it at low dosages, it would help with analgesia. But the problem you have to pay attention to is the sedation. Plus, the ketamine-induced psychedelic effects, right? Again, you want to be very careful when administering ketamine. Midazolam has been used. It will help alleviate some of that anxiety, taking care of that emotional aspect of it. Here in the red, I say you want to stay away from your NSAIDs. These are not patients that we want to administer Toradol to or ibuprofen, right? Stay away from the NSAIDs because they suppress uterine contraction and will promote the closure of the fetal the ductus arteriosus. So very important to stay away from the NSAIDs. So here in the US, we deal with the opioid crisis, right? It's here. So you may be thinking, well, am I advocating for something that would, replicate the opioid crisis now worldwide? I say no, right? If you do not want drugs, great. We always have options. The key thing here is which option works best. So we have non-pharmacological approaches that we can equally take. So for instance, having a supportive spouse. I don't know why a spouse cannot be present in the room during labor and delivery. Here in the US, I have 4 kids of mine. I was present during our birth, right? During the delivery of my second son, as soon as my wife went into labor, I was in North Carolina, she was in Boston. I flew back to Boston to be present, right? To be there for that extra support, which is why I said all adults should know this. We should be able to be present and support our spouses. We should be able to say, hey, honey, which pain, how can I best support you? Okay. And the presence of a spouse can significantly promote bonding between the couple as well. This is a good time to bond with your spouse and welcome the new baby. So I think as a culture, it's something that we should start thinking of embracing. You've heard of aromatherapy and massage and this. A spouse present can help with massage, right? Massaging the back, especially when the pain in the lower back is intense, can help. That gentle therapeutic touch can really enhance that pain experience by giving that emotional support, right? Remember when we started with the definition of pain, we said what? Sensory and emotional. The presence of a supportive spouse Or if the spouse is not present, right, the presence of a supportive significant other, it could be a family member, it could be mom, it could be a grandmother, or the healthcare provider presence can really augment that. Aromatherapy equally helps. Having good scent in the room, some of the things like roses, oils, those will equally help with pain. Frequent movement and positional change equally helps, which is what we see. If you've seen any woman in labor, you see them fidgeting, right? That is because they are trying to look for a position that is comfortable. Let's encourage that. That is something we can do as providers by saying, what position would be most comfortable? Can I give you an additional pillow? Can I give you a cold face cloth for your forehead? And again, just being present and talking to them in a compassionate way, you know? And I've added this section here to say, we all as providers can make a difference. Education goes a long way. During prenatal visit, talk to them about the experience of pain, the fact that they will experience pain and what they can do about it. Yes, even if they elect not to use pain medications, just knowing and what to expect is going to help with the pain, right? If you know what to expect, it's half the battle already, okay? Therapeutic communication, like we said, let's show that we care. Let's show that we are there for them, that we are there to support them through this. Instead of saying, that will be the opera food, open those picking go about, right? Things like that should not be coming from providers like us. We should be, communicating professionally. We should be respectful. We should be professionals, and we should really be showing some compassion. That goes a long way. It will help with the pain that they're experiencing, especially that emotional aspect of pain. Okay. So what are some of the challenges that I think of when you think of pain management for labor and delivery back home? Culture is a big problem, right? Before this, I was talking with Muna. I said, hey, imagine if this was pain that was being experienced by men, right? Back home, we are a very patriarchal society. If something is affecting men, not just, pretty much worldwide, there will be a solution to it, right? There is no doubt about it. If you have spoken to any man, they will tell you, it hurts, let's do something about it. So the culture, who sets the norm, who sets the expectation is playing in. So we have to change some of that. Health literacy is a big issue, right? You have so many myths and miscommunications out there. We have to talk to people. We have to educate them and tell the patients what they are going through, what to expect, what we can do about it, what are the potential effects, right? And of course, again, it comes back to us as providers, right? And the institutions. Access to care remains a problem, right? How many anesthetists are present in Cameroon when we say, epidural is a gold standard? How many anesthetists or anesthesiologists are present who are skilled in the administration of epidurals? That is a big problem in our society. Fetal and maternal monitors. How many women deliver back home without any fetal monitoring, right? So if that is why we say, giving medications is bad, because we cannot monitor the patient. So if we can have fetal heart rate monitors and maternal monitors, then there is really not much to be feared about, especially when you are giving modest dosages. The amazing thing is that in Cameroon, most people are opioid naive. So administration of just paracetamol, especially now that we have the IV form of acetaminophen, is going to give great analgesic effect because they're opioid naive. They've not had opioids and not been exposed to opioids just as the people in the West. So provider bias, again, right? That aspect of us coming in already thinking that, especially when it's that teenage mom coming in who is having a baby while still in secondary school, right? We come to it with our own biases and immediately start judging them and labeling them and thinking, right? That's that girl in school, right? Whose parents send her to school and she's not paying attention to school. So we start judging them. So those are things that we have to be very mindful of. And that is going to continue to be some of the challenges that we face. So to summarize my own part of this, again, labor is painful. If you've not gotten that, I think get that by now, right? It has physiological and psychological basis, personal, cultural, and experiences are going to really influence how much pain they experience. The woman's desire, childbirth preparation, and emotional support and adaptability is going to be very important. Opioids can help, but they have some effects. But equally, the good news is we have non-pharmacological interventions that we can use. Neuraxia and analgesia can provide optimal pain relief. And at this point, I will turn it over to Dr. Ngong to talk to you guys about neuraxia and other approaches.
Thank you, Dr. Aroke, for this amazing presentation. It's been so exciting, listening to you and learning that pain management does not just have a convenience factor, it equally has huge physiological benefits. While Dr. Ngong is setting up his slides, we want to check the temperature in the house because I can already see some reactions coming in. Dr. Ojo, welcome. We have some gynecologists in the town hall. We have mothers, we have pregnant mothers right here. So I just want to, check on the temperature in the house. So please, everyone, keep your questions till the end. After Dr. Ngong's presentation, then we'll open the floor. Right now, we just want to check on the temperature in the house. Dr. Ojong, how are you doing today?
I'm good, I'm good. Thank you. I'm
okay.
Good.
How do you see the temperature in the house? How are you feeling it?
Just right. No risk of hypothermia.
Okay, awesome. Okay. I'm happy to hear that. All right. We also have some of our mothers and sisters who've joined us for the first time, and I'm just looking at the names. I'm going to call on Akuini Mirabel. Mira, how are you doing today? Mirabel? Okay, maybe she's still muted. For the interest of time, we're just going to proceed, and then please keep all your questions, all your comments till the end, because I know there are quite a few. Dr. Aroke, you've pinched some raw nerves here, and people are very excited. So we're going to put you on the hot seat, you and Dr. Ngong, at the end of your presentations. So Dr. Ngong, over to you.
Make sure, can you see my slides?
Yes, we can.
Yes.
Okay. All right. Awesome.
Dr. Ngong, I'm sharing. I think I'm sharing for you. I don't know if.
Oh, you're sharing for me? Okay. Thank you.
Yes.
Yeah, that's okay. We can do that. Hold on 1 second. All right. So again, I'm Dr. Joseka Venantius Ngong, and thank you so much, Edwin, for that awesome presentation, and thank you so much for going into the physiology and talk, and also addressing the emotional aspect of labor and delivery pain management. And so without further delay, I will just go straight into talking about neuraxia anesthesia. So first of all, what is neuraxia anesthesia? This is actually the injection of local anesthetics, around the central nervous system, so the spinal cord. And, we're all familiar with at least had a procedure done at either a physician office, maybe taking out maybe excision of a lesion, maybe having a dental procedure, and they do use local anesthetic to numb up the area that is being operated on. And so in this case with neuraxial anesthesia, we're using similar local anesthetics, but except we're injecting them into the central nervous system. And that way we can achieve a blockade that blocks the transmission of signal or pain or sensory impulse from the nerve roots, to your central nervous system. And that way it takes away the perception of pain. So just a little bit of history, again, I kind of summarize the history because Edwin already touched on some of those points. The first epidural catheter was used for labor and delivery in 1949. And then in 1957, there was a game changer with the introduction of synthetic bupivacaine. And in a little bit, we'll talk about different kinds of local anesthetics. There are two main classes, esters and amides, and we'll talk about the difference and how bupivacaine offers a better advantage as compared to the esters, which were the first local anesthetics to be introduced. And in 1979, morphine was used in the epidural space. So again, with neuraxias, we don't only use local anesthetics. We can also inject some types of opiates into the epidural or into the subarachnoid space to attack the opioid receptors directly, without causing any kind of systemic side effect. And in 1988, there was the introduction of the patient-controlled epidural analgesia, and essentially it's similar to a PCA pump that is used in a lot of inpatients at the hospital for pain control, except this is for an epidural where you can set the pump to give the mom a continuous rate of local anesthetic infusion. But in addition, for breakthrough pain or for contraction, the mom can push a button that gives them an extra dose, which augments their pain control. And in 1993, the CSE, or which is combined spinal epidural, was introduced. And we'll talk about, what's the difference and why a combined spinal epidural is useful in certain scenarios. And of course, in 1996, ropivacaine, synthetic ropivacaine was introduced. Ropivacaine is similar to bupivacaine, except bupivacaine is very cardiotoxic. Meanwhile, ropivacaine is less cardiotoxic. And that's in the case where if you make a mistake and you inject this medication into the intravascular space. And so ropivacaine, even though it's less cardiotoxic, it actually has a shorter duration of action. Next slide. All right, so I just wanted to clarify this because throughout this presentation, we're gonna talk about analgesia versus anesthesia. Again, analgesia is pain relief without the loss of consciousness. And we all know with epidurals and with spinal anesthesia, the patient is conscious, the patient is awake. The only difference is that the patient has loss of sensation. And also with labor and delivery epidural, the goal is always to preserve muscle function, or at least some degree of muscle function, because like Edwin said, the mom actually, it's always good for the mom to participate. And for vaginal delivery, you actually want the mom to be able to push. And that also gives them some sense of satisfaction during the birthing process. The difference with anesthesia, so we can use epidural as analgesia, which is a pain control. And the difference is just in the concentration of the medication that we use, as well as we could use epidural as anesthesia for a C-section. So the difference is just that, again, if we're using an epidural as anesthesia, the patient has no loss, there's really no loss of consciousness. But in this situation, we actually have both sensory and motor blockade. Because, just imagine a C-section, a surgeon operating on the patient on a table and the patient is moving. No one likes a moving target. And so again, the difference comes in the concentration of the local anesthetic that we use and the ability to block both the sensory and the motor neurons. Next slide. All right, so this is just a little review of the anatomy of the vertebral column, because again, like Edwin said, the biggest challenge with performing epidurals and spinal anesthesia back in Cameroon is the lack of trained anesthesia providers that are actually trained and skillful in performing these procedures. And so you really have to understand the anatomy of the vertebral column, because you cannot stick a needle in someone's back when you don't even know what you're doing or what you're trying to, aim at. And so essentially, we're looking at that picture, we're looking at, the upper part, it just shows the vertebral column is made up of two parts, the vertebral body, which is the anterior or the ventral portion of the vertebrae. And then you have the spinous process and the transverse process that constitute the posterior section. And in the middle, you have the vertebral foramen, which is the canal within which runs the spinal cord. And you can see on each side of the spinal cord, you do have spinal nerves, and on the right and left side. And the spinal nerves are divided into the dorsal root or sensory root that carries pain signal from different parts of the body, feeds it into the spinal cord. From there, it synapses and then transmits the signal to the brain. And on the ventral root, you also have the ventral root actually carries consists of the motor. It carries motor signal, which is muscle movement, from the brain down to the specific area of the body, as well as it also contains, your autonomic B fibers, which is very important. And that explains why with spinal or epidural anesthesia, you see sympathectomy, which is the autonomic B fibers carry sympathetic input from the brain down to the blood vessels. And so we'll talk about that later in a little bit. But again, looking at the spinal cord, it's made up of 33 vertebrae, 7 cervical, 12 thoracic, 5 lumbar, and 5 sacral. And then you also have 4 coccygeal, which are all fused together. Next slide. And again, to better appreciate epidurals and what we do, and essentially how are we able to tell what area of the body that is covered by the epidural, you actually need to understand the dermatome. So a dermatome is essentially an area of the skin that is innervated by a dorsal nerve root from the spinal cord. Now, even though it looks like the dermatome is clearly defined layers, that's not the case. There is a considerable amount of overlap. So essentially, you do have certain areas of the skin that are innervated by branches from nerve roots at 2 different levels. So it's not a clear-cut, picture. In real practice, it's not clear-cut like you see on the picture. But again, Edwin did talk about, the pain pathways and everything. And so looking at this dermatome, that essentially tells you if I were to put an epidural and I want good pain control for a patient that is in stage 1 labor, how high should my epidural be? And that's where this dermatome relief comes into play. Next picture. Okay, again, I'm not going to go into this because Edwin already talked about it, and he did talk about stage 1 labor and the pain pathways. And so just looking at the picture, that tells you that if I were to put in an epidural, and my goal was to provide analgesia from phase 1 all the way through the whole 9 years of labor, you want to put in an epidural that's going to cover at least up to about between T11 to T9 in order for you to get full pain control. All right, and so what are the different Neuraxal analgesia, which also can also be used as anesthesia? We do have, of course, epidural, and we have intrathecal opiates, which is just spinal anesthesia without the use of local anesthetic, just using purely narcotics. And then, of course, spinal anesthesia, which is the same as intrathecal anesthesia, and then combined spinal epidural. Next. All right, so again, talking about anatomy, and actually one of the biggest things as providers is always to provide pain relief, but you also want to keep the patient safe. These procedures, in as much as they provide pain relief and help with a good experience as far as the birthing process, you can also cause damage to the patient. You can cause nerve injury, you can cause nerve damage, you can cause damage to the spinal cord. And so it's very important to kind of understand essentially where the spinal cord runs in the vertebral column, and essentially what to avoid when you are inserting a needle through someone's back. And so if you look at the picture, you can see around L1, which is your lumbar vertebrae, which is also called the conus medullaris. That's where your spinal cord actually ends. It's around L1, L2 for adults, and around L3 for the pediatric population. And then, but again, the dural sac, which is the subarachnoid space, continues all the way down, to around S2, S1. And so when you're performing like quarter blocks, that's around that area where you injecting your local anesthetic. Versus when you're performing a spinal or an epidural, our insertion site is usually around L3, L4, or sometimes we go L4, L5, if the patient has some kind of fusion, if the patient has, if you have trouble just accessing the L3, L4 interspace. Another thing to also think about is that, pregnancy also does causes changes in the curvature of the spine, especially the thoracic and the lumbar spine. And so with pregnant women, because of the baby and because of the pressure that it puts on the back, it can really make this procedure a lot harder compared to a non-pregnant patient. Next slide. And so this picture just kind of, it's a depiction of what are the different layers that we go through in order to get to the epidural space. And so again, you can see starting from outside, from the skin, you traverse through the subcutaneous tissue, and then your supraspinous ligament, interspinous ligament, and then your ligamentum flavum, which is the last layer before you get into your epidural space. And the truth is the epidural space is actually an imaginary space. And so when we identify this space, which is all by tactile feeling, there's no instrument or there is no imaging technique that can actually help the anesthetist identify the space. So everything is done just by the feel, and the different tissues have different densities, different consistency, and you can tell the difference when you're going from one tissue to another. And once we identify the epidural space, we usually inject either sterile saline or we inject some air in order to open up that space, and then it gives us room to thread that epidural catheter. But again, the epidural space actually is right outside the dura. So essentially, when you're threading an epidural catheter, the medication sits outside of the dura. And that explains why epidural takes a lot longer to set in as far as pain control compared to spinal, because the medication has to spread through the epidural space, and then it has to soak in the dural curve and then get to the nerve roots. And that's where the patient actually gets the benefit of the pain control. As opposed to when we're doing a spinal, with a spinal, we go through all the same layers, except we actually puncture the dura mater. And spinal, you actually get into the subarachnoid space, and how do you know you're in the subarachnoid space? You actually get flow back of cerebrospinal fluid, or CSF. And that's usually the definitive confirmation that you're in the subarachnoid space. And then you inject a local anesthetic, which actually mixes up with the CSF, and it blocks the nerve roots, as well as it also blocks transmission of signal on the surface of the spinal cord. We can go to the next slide. And again, just another picture with a little acronym on the side, if there are any students, anesthesia students or residents that are listening to the presentation, and it's just a quick way for you to remember, your different layers. Next slide. And so for epidural, usually we go through the lumbar vertebrae, which is, L3, L4. And with an epidural, you actually, once you identify the epidural space using a needle, you then thread an epidural catheter through that needle that sits in the space. And through that catheter, you can now give the patient, either you can give intermittent boluses, or you can hook up the patient to a continuous infusion, which is an epidural pump that gives the patient continuous flow. And that's the advantage of an epidural, because as opposed to a spinal, which is just a one-time injection and then only lasts for about 1 to 2 hours, depending on what type of local anesthetic you're using. With an epidural, you have the ability to prolong the pain control throughout the labor process. So essentially, you can control the patient's pain for as long as you want until the baby's out, and then the epidural can actually come out after delivery. And so that's the main difference. And this, again, I'm not really going to go into it, but just some typical concentrations that I use for my epidurals, as far as what kind of medication I use. And remember earlier I talked about the difference between analgesia versus anesthesia. So for analgesia, which is just using epidural for pain control, we tend to use really lower concentrations. And so you can see right there, the bupivacaine concentration is like 0.06 to about 0.25% bupivacaine, which is a pretty low concentration, but it's enough to provide sensory blockade, but without providing much of motor blockade. And in that way, the mom can still retain some muscle control, they can still push, and they can still participate in the whole birthing process. And alternatively, you could also use ropivacaine, which, like I said, is less cardiotoxic in an event of intravascular injection. And the concentration, again, a lot lower than you would use if it were to be a C-section, which is 0.1 to 0.2%. And sometimes we also do augment, the analgesic effect with opiates. So you can either use for epidural, you can use 50 to 100 mics of fentanyl. Usually, You can also use morphine as well, which you can use anywhere from 2 to 5 milligrams. But also understanding that, you know, when you use opiate, you know, for epidurals and spinals, you can actually have some itching, you know, after the C-section. And we'll talk about that, you know, when we're talking about complications. And again, it can either be intermittent boluses, or sometimes you can just do an infusion. And sometimes you can do a combination, which is where the PCA comes in, which is a patient-controlled epidural analgesia, which, like I said, you can set a continuous flow rate like a baseline, and then for breakthrough pain, the mom can actually push a button that will give them an additional bolus to augment the pain control. Next slide. So this is just a picture of someone, you know, performing actually placing an epidural needle through the back. So with this process, initially you hook up the needle to a syringe, you know, which can either be full of air or it can be full of saline. Saline is preferred, you know, because with saline, there is less chance of actually, you know, there's less chance of having post-dural puncture headache, which we'll talk about later down the slide. But once you identify your epidural space, which, like I said, you know, how you identify it is by loss of resistance. So when you're going through the skin, subcutaneous tissue, supraspinous ligament, intraspinous ligament, ligamentum flavum, what the provider does is they try to push the saline through the needle. And when you're in those tissues, you actually feel a resistance. So you cannot push the fluid into the tissue. But once you reach the epidural space, there is a loss of resistance because there is nothing opposing the flow of the saline through the needle. And that's how we identify that space. In addition, when you push the saline into the space, it helps opens up the epidural space and it gives you room to thread your catheter. And again, you know, I already kind of talked about, you know, spinal, which is, again, with spinal anesthesia, we typically would do spinal for C-sections, you know, because with C-sections, you want, you know, a more profound block. And what I mean by a more profound blockade is you actually want to achieve both sensory blockade, which is analgesia, and you also want to also make sure that you also have motor blockade because you don't want the patient moving on the operating room table. And so typically we'll do a spinal, which with a spinal, it's actually quicker acting, you know, within 5 minutes, the patient has complete motor and sensory blockade. But also with a spinal, it only lasts for about 1 to 2 hours, depending on what type of medication you use, depending on the dosage. And spinal anesthesia we can also augment the pain control with intrathecal fentanyl, which we use a much smaller dose, 10 to 25 mics. Or we can also use intrathecal morphine, which typically we use anywhere from 200 mics to about 500 mics. And typically we use 0.75% bupivacaine for spinals, which is a higher concentration because, like I said, in this situation, we're trying to achieve both analgesia and anesthesia. So we use a stronger concentration to get a more profound and dense block. And so again, just a needle of a provider. And this, by the way, just a disclaimer, this is not a picture of me performing that procedure, because when I put up this picture, the first thing I noticed was the provider has about 5 cc's of whatever he has in the syringe, I guess some kind of local anesthetic. And in the United States, we actually recommend do not use more than 2 cc's in your spinal, because you can have a high spinal, or what is called a total spinal, and it's not good. And we'll talk about that under complications. And so, but again, this is just a picture to kind of give you an idea, you know, what a spinal needle looks like and what performing a spinal actually on a real patient looks like. And again, once more, this is just a side-by-side, you know, comparison of epidural and spinal. You know, on the right side of the screen, on the right side of the screen, you can see the epidural anesthesia, and essentially you can see a needle actually going into the epidural space, and you can see the probably injected some saline that has opened up the space, and then they're threading a catheter into the space. And the big question is always how much catheter should you thread into that space? You know, in a 70-kilogram patient, the average distance from the skin to the epidural space is about 3 to 5 centimeters. But it is recommended that for optimal function of the epidural catheter, you actually want to leave at least 3.5 to 5 centimeters of the catheter in the space. because if you thread too little of the catheter into the space, and then you risk having a failed epidural. If you thread too much of the catheter into the space, you can either get into a blood vessel, which we'll talk about in a little bit, or you can have what is called a one-sided epidural, where your catheter actually leans more to one side of the central nervous system, and your medication does not spread evenly on, on both the right and the left side of the spinal cord, and that usually sometimes would lead to what we call a one-sided epidural. And then once the catheter is threaded into the space, and you aspirate to make sure that there's no CSF flow back, and then the needle is actually pulled backwards over the catheter, leaving the catheter in the epidural space, and that way you can use it for your infusion. And on the left side of the screen, again, is just a picture, showing a spinal anesthesia, which in the spinal, in that case, you can see the needle is all the way into the subarachnoid space. So right here, you can see the spinal cord in, other structures, and you can see the dural sac and then the cerebrospinal fluid around it. And you can see the needle is actually sitting right inside the cerebrospinal fluid. And that's why the spinal has a much quicker onset, because you're injecting it right in that CSF, and then it spreads all around the spinal cord and provides direct blockade. And this is, on the right side of the screen is just a depiction of an epidural needle. It's actually called a two-way needle. And if you notice, the needle has some kind of a curved tip. And there's a reason for that, because, you don't want the tip to be pointed, because it can easily cause a dural puncture during placement, which can be a lot of problems afterwards. But this picture actually does show, a combined spinal epidural. So there are instances where a parturient is in so much pain during labor. I mean, they are like just in excruciating pain, and you're called to put in an epidural. You know very well an epidural takes much longer to kick in. It takes about, anywhere from 50 minutes or more to get the full benefit from an epidural, to get complete pain relief. But in the case where you actually want the patient to get an immediate relief, you can do what is called a combined spinal epidural. Or if, say, you're doing a C-section and you're working with a slow surgeon that takes more than 2 hours for their C-section, that is also another scenario where you might do a combined spinal epidural. So essentially, what you do first is you use a two-way needle, you identify your epidural space, by loss of resistance, and then using a needle through needle, you insert a spinal needle that goes past the tip of the epidural needle and then punctures through the dura mater into the subarachnoid space. And that way, the advantage is that you can inject local anesthetic into the subarachnoid space that will give you almost immediate blockade. But then you can also thread an epidural catheter in the epidural space. For when your spinal wears off, you can use the epidural to prolong analgesia and anesthesia, depending on what you're trying to achieve in that scenario. And so that's an example of where we use CSEs. Another place where I use CSE, which is not in obstetrics, is with total knee replacements. Every now and then you have a surgeon that wants to do bilateral total knees. Most often patients come for just one knee replacement, but there are times when the patient elects to do both the right and the left side. And we typically do these procedures under spinal anesthesia unless there's a contraindication. But again, a spinal anesthesia only lasts for 2 hours. And if they're gonna do a bilateral total knee replacement, it's obviously going to take you at least, you're looking at 3 hours plus. And so that's another case where I usually will put in a CSE. So when my spinal wears off, I can actually prolong my blockade using my epidural catheter. Next slide. And other techniques, that are used, in OB anesthesia, we actually Edwin did touch a little bit on the quarter block, which I did talk about, which is, again, a quarter block is essentially, it's just like, doing a spinal, but you placing the spinal a lot lower. You're injecting into the epidural space, you're injecting right around the coccyx bone, and typically this is really good because it covers that sacral, that sacral and lumbar plexus, which is really, that area that, which is really the sensory input that actually gets the most that plays the most part, with active stage of labor. And so caudal anesthesia is not performed so much in adults, but you see it a lot more done in pediatric populations for procedures such as circumcision and other, other procedures that are done with around the perineal area for like neonates, but not so much in adults. But again, it's still an option. And then paracervical blockade. So with paracervical blockade, the local anesthetic is injected into the tissues around the cervix. And that way it reduces the pain caused by the contraction and stretching of the cervix. It usually lasts, very short acting, about 1 to 2 hours. And used more for first stage of labor. But the downside is that it can actually cause, the baby's heart rate to slow down. So it can actually cause decelerations. And if you've ever done OB anesthesia, for sure, the OBGYNs do not like decelerations. That's usually a sign that the baby is not doing well and something needs to be done. And so that being a side effect of a paracervical block, it's really falling out of the wayside. It's not, personally, I've never done one, but I just read about it in textbooks. And then we also have pudendal blocks, which usually play a better role during the second stage of labor. And so it actually involves injection of local anesthetic through the vaginal wall. And the goal is to also catch the pudendal nerve, which is in the pelvis. And it numbs up the perineum, which is the area around the vagina and the anus. And it just makes that second stage of labor a lot more comfortable for the patient, because a lot of the pain is due to stretching of the pelvic floor from the baby descending into the birth canal. Next slide. And most recently, especially in Europe, there's been the whole idea of using nitrous oxide. Nitrous oxide is it's an anesthetic gas, commonly called laughing gas, that is used a lot, especially for dental procedures. But I think this all started in Europe, where they're using a 50% mixture of nitrous oxide and 50% mixture of oxygen, and they've come up with a delivery system where essentially it's like a mask that is put over the mom's face, and they essentially breathe this 50% mixture of oxygen and nitrous, and they actually say that it actually provides pain control, especially for stage 1, for the first stage of labor. I've never used it. Again, I cannot really speak much about the efficacy, from a personal experience, but at least the literature suggests there is some benefits. So I just thought, I would include it, especially for a scenario like Cameroon, because this new technique actually does not require any kind of additional training. Essentially, all you need is to buy the delivery system and then just train the staff on how, to monitor the mom and just make sure that the patient does not get too sedated. And, this could be something that can easily be utilized in a setting like Cameroon, where epidurals and spinals are not something that is available at every healthcare facility. And this is just a study that actually looked at the whole efficacy of nitrous oxide. And so it was a systematic review that included about 58 publications. But however, the outcomes on the individual studies were so different that the authors had a tough time actually synthesizing the results to come up with a definitive conclusion on the efficacy and the benefits of nitrous oxide. And so essentially this study did not really come up with any strong recommendation to say, hey, you know what, I think nitrous oxide is a new thing, we should all use it. But however, what they noticed was that there was no significant difference in the APGAR scores, from the patients from the parturients that utilized nitrous oxide during the labor process compared to parturients that did not utilize nitrous oxide. Another thing they noticed was that there was a higher incidence of nausea vomiting, which me and Edwin already know that with nitrous oxide, it actually increases the chances of having post-op nausea vomiting. And also they noticed there was a high incidence of dizziness and drowsiness during the labor and delivery process. And I mean, if we're moving away from opiates because we're trying to avoid the mom from getting dizzy and drowsy, but yet nitrous oxide is causing the same effect, and then that really supports, the recommendation that epidurals are really the gold standard, because with epidurals you do not get that sedative, effect, and also the medications are sequestered in the central nervous system, so there is no risk of transferring or the baby of any fetal maternal transfer through the placenta. And so again, not everyone is a candidate for epidurals, in as much as they provide a much superior pain control, in as much as it's a gold standard. There are times when it's not done on every parturient, and one of the biggest, there's really no absolute contraindication to an epidural, except the only absolute contraindication is the patient refusal. So essentially, if you were to offer the patient epidural and they refuse, you cannot force them to get one. It has to be their choice. You can only explain the benefits, and at the end of the day, it's up to the patient to make that decision. And so that's really the one and only absolute contraindication. And of course, coagulopathy, which is if the patient has any kind of bleeding disorder, if their clotting factors are actually abnormal, low platelet counts less than 100,000, it is recommended that you do not perform any kind of Neuraxia block, because you run the risk of actually having a epidural hematoma, which is a life-threatening emergency. And the other contraindication is high intracranial pressure. So in patients with any kind of brain tumor, patients with altered mental status, and you're suspecting maybe the patient has an increased ICP, you actually do not want to perform any kind of dural puncture, because it can actually cause herniation of the brainstem, which can lead to really bad outcomes. And then the other relative contraindication is sepsis. So if a patient has sepsis, which is an infection in the bloodstream, you can actually introduce you can actually introduce the bacteria past the blood-brain barrier into the central nervous system, which can cause meningitis. So that's another consideration where if a patient were to have a positive blood culture, and then we will not want to perform any kind of dural puncture. The other relative contraindication is hypovolemia, and the reason is because spinal anesthesia, epidural anesthesia also causes a blockade of your autonomic input. And so what that causes, it actually leads to vasodilation. And this vasodilation actually causes, that's what causes the whole drop in the blood pressure when you actually, when you inject local anesthetic for spinal, or when you start an epidural. And so the drop in blood pressure is a lot profound for patients that are already hypovolemic, but there are ways that we can actually mitigate or prevent this. Usually, if we know we're gonna place an epidural or place a spinal, we usually give orders for the OB nurses to actually start like a fluid bolus on the patient. So usually what we call, preloading the patient with some fluids. And that way, we can minimize that hypovolemia and minimize the sympathectomy that actually is a side effect of autonomic blockade. And then patients with valve lesions, like patients with aortic stenosis, mitral valve stenosis, where definitely they really depend on their venous tone to maintain a normal blood pressure and to maintain perfusion of the myocardium. It's actually recommended that, in severe aortic stenosis, mitral valve stenosis, or hypertrophic cardiomyopathy, you don't want to actually perform a spinal, because the sympathectomy that leads to vasodilation can actually lead to life-threatening complications. And structural changes in the vertebral column, such as scoliosis, patients with arthritis, degenerative joint disease, patients that have had any kind of back surgery, laminectomy, discectomies, patients that have had spinal fusions, you really want to get a good medical history That way, you can make an informed decision, and also make sure that the patient is aware that you might not succeed in actually performing an epidural or a spinal, or it might have to take you more than just one try to actually successfully place the epidural or spinal. And also patients with difficult airway, most often we think that when we do an epidural or a spinal, we're essentially getting away from not intubating the patient. But then what if you have some kind of complication? What if you have a high spinal and the patient goes apneic or the patient goes unconscious? What if it's a C-section and the patient ends up with postpartum hemorrhage? Or what if it's a vaginal delivery and the patient ends up with postpartum hemorrhage and they have to come to the operating room for some kind of a surgical intervention? You still have to intubate the patient. So it's very important. If it's a patient, the OB population actually already present with difficult airway as a result of the changes that occur with pregnancy. But again, patients that have other issues that make them a much more difficult airway, you might want to reconsider and think of other options. And full stomach. So again, the whole point is just because you put an epidural or spinal doesn't mean the patient cannot aspirate. Very often when you're coming for a surgical procedure, we ask that you not have anything to eat or drink at least the night before the procedure, for at least 8 hours. And same thing applies for labor and delivery, because the hypotension that occurs as a result of the sympathectomy with spinal and epidural can actually cause nausea, vomiting. And if this patient throws up and aspirate, then they can end up in a ventilator. They can end up with a pneumonitis, and usually that's not a good outcome. And patients with any kind of neuropathy, any kind of nerve damage, any pre-existing neurologic condition, you actually want to do a really thorough pre-op examination and make an informed decision if an epidural would be, or a spinal would be a best option for them, because you don't want to exacerbate that problem. And generally, the literature has always recommended that for patients with multiple sclerosis, that you avoid spinal anesthesia, because that can actually worsen their symptoms. Next slide. And complications. And so I did mention earlier about the reason why you don't want to perform an epidural or a spinal on a patient with coagulopathy, on a patient with low platelet count, on a patient with high PT, INRU, patients with a high APTT, or patients with their bleeding time twice the normal. The whole reason is because you run the risk of actually having an epidural hematoma. And so that's bleeding in the epidural space that can cause accumulation of blood between the bone and the dura. And this compresses on the spinal cord, which can cause ischemia. And if that hematoma is not decompressed within 8 hours, it can actually lead to permanent neurologic damages. So it can lead to permanent paralysis. And so that's a big issue, and you don't want to find yourself in that situation. Also, respiratory function, especially if you perform a spinal and you have a high spinal anesthesia, it actually can impair your accessory muscles or the intercostal muscles. And so sometimes it can lead to weakness in your respiratory muscles. And this is not so much of a problem in the in the pregnant women, because a lot of the time, pregnant women are young, healthy, no pre-existing pulmonary condition. So typically it's not an issue, but then you think about it more when you're performing spinals in geriatric population, like for knee replacements, and you have some of these patients come, they already have end-stage COPD, they have some kind of pulmonary fibrosis and other issues that already makes them a higher risk, and that could be a problem. And so it's just something to think about. Cardiovascular, we did talk about, the vertebral column earlier. One thing I forgot to point out was that, your sympathetic output that from your central nervous system to your heart, it actually is supplied by your nerve roots between T1 and T4. And so if you actually were to inject a really large volume of local anesthetic into the subarachnoid space or into the epidural space, you can actually cause you can actually block the cardiac accelerators, and that could lead to total cardiovascular collapse. And so That's a complication that is rare. I've never had it, but it's possible. And if that happens, and then essentially you just live on an opposed parasympathetic nervous system activity on the cardiovascular system. And that will lead to hypotension, bradycardia, and, you know, it can actually lead to cardiac arrest. And, you know, this is usually a situation where you have to start epinephrine drip, you know, you have to secure the airway and fluid boluses and other interventions in order to stabilize the patient. And so that's one reason why I mentioned earlier that in the United States, we generally avoid using, for spinals, we generally avoid injecting more than 2 cc's of local anesthetic into the subarachnoid space. And then post-dural puncture headache. Which is with post-dural puncture headache, again, it's severe headache that can occur as a result of actually as a result of the dural puncture, you know, which can occur with spinal. Very rare with spinal because we use a small 25 gauge needle for spinal. So the puncture that, you know, the hole that we create on the dura is not enough to provide a big of a CSF leak to cause a post-dural puncture headache. But then, especially for providers that are not experienced, that are performing epidurals, there is that risk that sometimes they might get past the epidural space and then cause a really huge tear on the dura. And that can cause a huge CSF leak, which leads to changes, which produces a really severe headache. And I'm sure, you know, if there are moms in this forum that have been through that, it's not a good experience at all. You know, it's something that you want to avoid because it's a really excruciating headache. And actually, you know, the treatment is not the most comfortable thing because we actually treat that with a blood patch. Or sometimes we do, nowadays, there's a new treatment which is called a sphenopalatine block. But again, you know, a blood patch is not a benign procedure. And it's, you know, the best way to avoid that is just not to cause any kind of dural puncture. And also pruritus, which is itching from the opiates, from intrathecal opiates, you know, that's another complication. And if you have a high spinal and you have your opiate actually spreads all the way up into the brain, then that can also cause respiratory depression. It can lead to nausea, vomiting, and also urinary retention. And we did talk about, you know, bacterial meningitis, which can result from sepsis. And there are other complications such as coda equina, which is related more to using high concentrations of lidocaine, 2%, greater than 5% lidocaine, and transient neurologic symptoms. Next slide. And so with epidurals, they actually do have, you know, blood vessels, which are called Barton's plexus that run in the epidural space. And sometimes, in a, you know, not on purpose, the epidural catheter can actually get inserted into those blood vessels without the provider's knowledge. And that's why before we inject any kind of medication through an epidural, we always aspirate to make sure that there's no blood return. And then we also aspirate to make sure it's not in the subarachnoid space. But you know, what can happen if the epidural catheter finds its way into one of those blood vessels? You can actually inject a large volume of local anesthetic into the systemic circulation, which can cause local anesthetic systemic toxicity. Again, it is, you know, it can, depending on how much the dosage, you can either have mild symptoms such as psychomotor numbness, lightheadedness. The patient might complain of ringing in the ears, which are usually warning signs. They might have visual disturbances, slurred speech, and at that point, you should really worry because that means you definitely have injected such a high amount enough to create the local anesthetic systemic toxicity. And that can progress all the way to cardiovascular collapse. The patient goes apneic, has a coma, and they can have a grand mal seizure. And we actually do treat this toxicity with 20% intralipid, which we're not going to go too much into that today for the sake of time. Next slide. And I just wanted to touch a little bit on, you know, just again, pharmacology, you know, local anesthetics, you know, you have two main classes of local anesthetic. You have the amides and you have the esters. And the biggest difference in there is in the structural, is the structural difference of this local anesthetic. but then also, you know, how they're metabolized, you know, and also the duration of action. Typically, esters are metabolized by pseudocholinesterase in the plasma, and that usually makes them actually have a much shorter half-life compared to amides that are metabolized in the liver. Another thing also to remember is that, you know, when esters are metabolized, they actually do produce what is called para-aminobenzoic acid, or PABA. And that actually causes allergic reaction in a lot of people. And it's pretty interesting. Para-aminobenzoic acid is actually one of the powdered crystals that are actually used in a lot of beauty products that are used by women, you know, lipsticks and makeups and all of that. And so one thing I always ask my patients, if I were to use an ester to perform any kind of block, is ask them if they've ever had any reaction from lipstick. And so just a little FYI. Next slide. And we already talked about, you know, dosages. You can just skip that. Edwin, I think it's kind of a repetition. And Edwin actually, again, Edwin had a similar slide, which I talked about, you know, why Neuraxal analgesia or anesthesia is better in the OB population. And again, we talked about it provides complete analgesia. So it provides complete pain control. There's no maternal sedation. The mother is able to enjoy and participate in the birthing process. You know, it mitigates deleterious reflex responses to pain. There's minimal or no neonatal sedation. You know, with epidurals, you can do continuous analgesia because you have a catheter, so you can actually infuse local anesthetics for as long as the labor process is actually going to last. Again, biggest disadvantage, like Edwin mentioned, was, you know, it requires a skilled anesthesia provider to perform these procedures. Next slide, Edwin. And this is just a couple of slides that I added, you know, which is just, again, looking at, you know, I've had a lot of female friends ask me, like, should I really get an epidural when I'm, you know, when I'm having a baby? And my answer is always yes. And I just put up a few slides just to kind of, you know, provide, you know, some of the evidence that actually supports, you know, that recommendation. And so this study actually looked at, you know, pain control. You know, it was a systematic review. And so what they looked at was compared patients that received epidural analgesia during the birthing process to patients that actually received non-epidural analgesia, which means other methods of pain control, such as parenteral opioids, and non-pharmacologic pain control. And so what the study realized was that patients that actually received epidural actually had better patient satisfaction. And when we started this presentation, that Elvis did mention about customer service in Cameroon, and he talked about the concept of it's not just what you do, but how you make the person feel. And patient satisfaction is a big deal. You know, it's a really big deal. And it's something that I think is really lacking in Cameroon, but even in the United States, it's actually a work in progress. And that's the reason why a lot of hospitals have come up with the HCAHPS score, you know, with post-hospital surveys that is sent to patients to actually, for them to actually rate the hospital and rate the providers based on their experience. And so, you know, when you look at that and you really think about patient satisfaction, and that the people that got epidural got a better patient satisfaction, it actually does reflect on this HCAHPS and Press-Ganey scores, and it actually does make the hospital look good. And actually, it brings us business, and also, you know, in terms of just in terms of satisfaction as a provider as well, you also feel that satisfaction, like you made a difference in, you know, in the birthing. You made a difference in actually helping that mom have a good experience during such a tough and during such a really painful moment of their life. And the other things that were revealed in the study was that, you know, patients that got epidural, of course, they had way more better pain scores. So their pain was better controlled. One thing that they also realized was there was no difference in the APGAR scores. So there was no significant difference in APGAR scores NICU admissions, which is neonatal intensive care admissions. And also another thing that they also realized was that, or the only disadvantage was they noticed that patients that receive epidural tend to have a more prolonged stage 1 labor. And so, which means that the labor actually took a lot longer than it would have taken without epidural, but then they had better pain control. And patients with epidural actually were likely to actually receive oxytocin augmentation or Pitocin drip, in order to augment their uterine contraction to help speed up the delivery process. Next slide, Adrian. And then the other issue too was looking at, because again, when you give patients parenteral opiates, you're not just worried about placenta transfer to the baby. You're also worried about after the mom has the baby, how soon can they breastfeed the baby? Because all these drugs are lipid soluble, and no matter how much your body metabolizes them, you can actually pass some of these drugs through breast milk to the baby, and that can also cause neonatal depression even after the baby has been born. And this study actually looked at using fentanyl in the epidural space. How does that affect the ability for the mom to breastfeed the baby? And so what they found was that using fentanyl concentrations as high as 200 mics per ml did not influence breastfeeding rates, after the delivery process. So essentially, the mom could still breastfeed the baby without worrying about the baby, getting any kind of respiratory depression or getting any kind of sedation effect from the fentanyl getting passed through the breast milk. Next slide, Adrian. And then, again, Edwin did talk about, I did mention earlier about, epidural actually prolonging, first stage of labor. And this was just comparing epidural versus parenteral opiates on the progress of labor. And again, like I said earlier, it was noticed that patients that receive epidural tend to have a more prolonged labor. But again, pain-free is prolonged, but it's pain-free compared to patients that receive parenteral opiates. It's a shorter, they do have a shorter duration of labor, but with much less pain control. Go next slide. And Adrian actually touched about the emotional aspect of pain control. And so when I was doing a little bit of reading before this presentation, I kind of was like, okay, is there really any association between, because epidural offers much superior pain control, is there any correlation between patients that received epidural and the incidence of having and the chances of having postpartum depression versus patients that did not receive an epidural and having postpartum depression? And so what this systematic review actually revealed was that there was no significant difference in the incidence of postpartum depression. But again, we do know that really painful birthing experience can be traumatic, and I think it definitely plays a role. But actually, this systematic review did not see a strong correlation. However, the population that received epidural had better patient satisfaction. Next slide, Edwin. And again, just taking it back to opioid crisis, again, over 20% of pregnant patients are prescribed opiates, and approximately 3% receive prescriptions for greater than 30 days. And, opioid crisis is a big deal in the United States, and not just in the United States. I think it's a global crisis now, because I remember December when I went to Cameroon, it seems like there is a big issue with tramadol, and, actually look like they have a drug abuse issue in Cameroon, which I did not think of that when I was growing up as a young boy in Cameroon. And so, it's very important that when we think about using opiates during labor and delivery, we also have to think about, what are going to be the chances of the mom actually becoming dependent, or is there any kind of correlation between use of opiates during the laboring process and the chances of the mom eventually, abusing these drugs in the future when they don't even need it. Next slide, Edwin. And so this study that I looked at actually looked at that question, which is like, is there any kind of correlation between, the use of fentanyl during the labor process and the chances of the patient actually abusing the same type of opiate, even after they had the baby and they're back to normal life. And the study actually did reveal that there was overwhelming evidence that showed correlation that, the use of fentanyl to manage maternal pain during labor actually showed that these patients were likely to abuse fentanyl, as their drug of choice, after they were already done with the labor process. And so it's something to think about as providers when we are addressing pain management with labor and delivery. Next slide, Edwin. And at this point, I'll leave it at that, and we'll keep it open for questions and any kind of discussions. Thank you all.
Really, really, really exciting.
Thank you so much.
Thank you. This is exciting. Elvis, I don't know what you think about this, but I just started literally taking down notes. I'm like, this is deep.
Yeah, this is really interesting, and I feel like it's been, someone had mentioned in the town hall that we need to make this to be some kind of CE where people can get, some kind of continuous education credits just by being part of the town hall. So this is really amazing. Thank you so much, Ngong, for this excellent presentation.
Thank you so much.
And maybe, Elvis, just a quick comment as we're diving into the question sections. Please, if you don't mind, just turning on your camera so we can get to talk to you and see your faces. This is a very interesting discussion part, and we just look forward to getting to meet everyone. And yeah, the question section is open. Oh, Elvis, over back to you.
Yes, and Alison, I realized that when Edwin was presenting, I put, but the image that was pinned on camera was that of Vanessius, and so just excuse us for that. But these are the two gentlemen that just did the presentation. Edwin did the first presentation, and Jessica just did the second presentation. So we want to thank you so much for this excellent presentation. Of course, Brian, what is your take about the presentation before we start receiving questions?
Yeah, I think it was really great, really deep expert opinion view on the state of anesthesia. It's a very important subject. So many things to talk about, and I'm really looking forward to the question answering session as well. Thinking more about the public health implication, I think Dr. Lemonge Norbert already raised some of this, the public health implications of this subject, and I really hope that, looking forward to that exchange in the Q&A session.
Great. Alison, you already have some people in mind who are already bubbling with questions. You want to take it while they get some breath?
Osric's hand has been up for a while. I think even since Dr. Aroke was still presenting, looks like he touched a note with Osric. Osric, can you please ask your question?
Yeah, can you hear me?
Yes, we can hear you clearly.
Yeah, thanks for this very, very useful talk. Obviously, it's my area of expertise, being an obstetrician and a perinatologist, a maternal and fetal medicine person. So it was really useful to listen to this, and thanks to the speakers for quite a comprehensive talk covering all the issues. Two things. I think, having trained back home many years ago, well, home as in Nigeria many years ago, and having practiced in sort of the UK, and then coming now and practicing in the Middle East, it presents obviously multiple perspectives. I think the most important thing really in terms of pain relief and the management of pain in labor starts with education antenatally. The women need to know what their options are. Obviously, this is dependent on where they live, but even with very minimal resources, you can still make a big difference. And that's one of the things where you look at staff attitude. Now, having worked with midwives in different areas of the world, there's some fantastic midwives in Africa, certainly in Nigeria. I don't know so much about Cameroon, but you get the vast majority who you wonder why they went into the profession. Okay, obviously they need a job, but they're not particularly sympathetic or supportive to the women, and that makes a massive difference. So once the women know what their options are, when they turn up in labor, the attitude of staff is critical. The presenters touched on the role of support people. Now, this doesn't have to be a medical personnel. It can be, you know, a wife, a sister, a doula, someone that's just there to support and help that person. And that makes a big difference in terms of the management of their labor. For women, breathing exercises are useful. So just by helping them to breathe with the pain can be some way to minimize the pain that they're having. There's a role for water. Certainly in the UK, you will find that there's a role for water beds. A lot of women who would consider delivering at home or home deliveries will use water as a source of pain relief. And that seems to work quite well. So they stay in water until the later stages, and some will actually deliver in water. But this is obviously something that you have to have the expertise in terms of midwives and the staff that will encourage them to do that. Then there's obviously oral pain relief. We use paracetamol as a first line. Then we use the hydrocodone. I don't know what you guys call that in the States, but this is obviously slightly stronger oral pain relief. And that's always the second line that we use in labor. In terms of pethidine or the opioids that we use, you want to give them early in labor because obviously later on they cross the placenta, can impact the baby's breathing at delivery if you give them close to the end. There was some discussion about Entonox or nitrous oxide and oxygen. This is widely used in Europe. It's quite common. It's also sort of sometimes described as laughing gas. It is not perfect, but it sort of buys time. So in the beginning stages of labor, where the women want to be mobile, they want to be able to walk around, then it's something that they can use before they get to the stage where they need an epidural. And for some people, that's enough to control their pain. So it really is a multitude of approaches in terms of pain relief, and particularly if we're talking about sort of home environments where the resources are limited, then, you know, these little sort of attitudinal things, simple things are the things that will go a long way to sort of improving the experience that women have in labor. Because obviously you can't provide an epidural in those settings, but you can certainly make a change in terms of attitude and improve the experience that they have. So thanks you guys for this. It was fascinating listening to this, and keep up the good work. Thank you.
Thank you, Doug. Thanks for that contribution. I'm going to open the floor and take up a few questions, but before I do that, I'm going to put Edwin and Vena on the hot seat. Truly, you mentioned quite a couple of things, from aromatherapy to having a spouse in the delivery room. If I am a Cameroonian woman and I go back home now, I want to go and give birth. I'm not going to Hôpital Général Douala. I'm a student. I cannot afford to give birth at Hôpital Général Douala. I go to, say, La Quintini labor room, where you have 10 beds there, and all you have maybe 5 different women in labor just laying there, you know, ready to push out their babies. And I'm crying there in pain. What are my options? Like, I mean, aromatherapy is not going to be feasible. Water birth is not feasible. My husband cannot get in there because then he's going to see other people's wives laying there naked. What are the options that, you know, can be used for me to provide some relief in my pain during labor? What options do I have? So that if I go, I mean, when I talk about options, I'm a student. I don't have money to pay for an anesthetist consultation because he will charge me a lot of money and I cannot afford. So if I go to see my midwife or the doctor who is following me, what are the options I can discuss with him as I prepare to give birth?
So I would start with that. I think that's a great question because, again, we have to be aware of the availability of resources and the privilege that we have being in the West. I think for a start, you know, analgesia and pain management starts with just being aware, right? As you think about it, you know, it's kind of like you have a long road trip to go through. Mentally preparing yourself for that road trip is half the way already, right? So just that mental preparation of saying, okay, this is, and having that open discussion with the provider to say, okay, this is going to be painful. This is what you should expect, right? So stage 1 labor, okay, typical labor is going to last X amount of time. And with time, as the contractions increase, you're going to have more pain. Once the lady is aware as a student, if you already anticipate and know that this is going to happen, that is a plus. The second thing would be like the breathing exercises, right? If we know that at the beginning of each contraction, you can control your breathing, then you can equally control how much pain you are feeling. Distraction can go a long way, right? So if you anticipate that pain is coming, and you, for instance, you focus your mind on something else, that distraction is for free, right? You can virtually do that. Those are things that are within your control. If you want to go to pharmacological interventions, which are not expensive, you can talk with your provider about the availability of Tylenol, right? There are many women who are not even offered even something as basic as Tylenol. Right? And that is something that is relatively cheap and readily available, which can be taken. Right? Then we can then go into other more expensive things, which as a student may not readily be available. But I think a big role is just making sure that you've had that conversation. Equally, your spouse may not necessarily be present, especially in today's day and age with the availability of FaceTime and all this visual technology. I think having a spouse who is not necessarily present in the room, but can communicate with you and extend that sympathy. And it may not be a spouse, it may just be a good friend, somebody that who can coach you to say, okay, I'm in this with you. You are not alone, And of course, like I said, the role of the providers. I think those are things that would be can be very helpful.
And I'll just add on to that, Alison, very simple things like just changing positions. Certain positions such as sitting upright has been found to be a lot more to offer some pain relief. And I can attest to that. Every time I go over to the OB unit to put in an epidural, 99% of the time you find the mom sitting on the edge of the bed. Sitting upright, standing up, maybe if you can take a few steps, all of that actually helps to provide some pain relief. Also, superficial heat and cold, in Cameroon, at least if you're a student, you're poor, but you can still afford, maybe get someone to get you a tangy bottle from the fridge, wrap it in a towel and kind of hold it against, that provides some comfort. As well as warm compress, maybe you can either soak a towel in warm water, or the same thing, you can warm water, not hot, because you don't want to cause a skin burn, but you can warm water, put it in a plastic container and then hold it against your skin. And also some literature has actually described counter pressure. So essentially, how you put your arms, you use your heels of your arms against your hip, apply pressure. That has actually also been shown to actually relieve a lower back pain and pressure, which is actually one of the biggest issues, especially during the active phase of stage 1 labor, when the baby is descending into your birth canal. So those are things that you can easily, those are non-pharmacological methods that you can utilize without actually spending a dime.
Okay, thank you very much, Doc. So I'm going to just quickly call on Dr. Zikonta. I know we have a lot of people's hands that are up. So after Dr. Zikonta's intervention, we're going to take some questions. Since we are many of us and we're running short on time, please, when you get the chance to talk, just briefly tell us where you're calling in from and keep your questions succinct. So Dr. Zikonta Raymond, can you just tell us a little bit about what you and your colleagues have been doing home? I know you're one of the few people back home who are trained with skills in anesthesiology. Maybe you want to shed some light on what's been going on practically.
Yeah, thanks a lot for giving me the floor. I really am very pleased that we had this topic today because it's one of the topics that touches my heart, especially given that I'm one of the people involved actually in the practice of anesthesia in Cameroon. And I enjoyed both presentations. They actually gave us the basics, the basic concepts that need to be understood in order to have a view on how pain should be managed in delivery. And unfortunately, being in Cameroon, being a practitioner, that we can only give what we have. And there are so many shortcomings which do not only depend on us, but depend also on the system and the organization of things this way. But as a specialist, my own experience is I do a lot of epidurals in women. I actually work in the Women and Children's Hospital, so it's like part of my daily experience, part of the things that I do in Cameroon. And technically, it is, I would say, epidurals, as Elvis presented, is one of the best. It's one of the best means of managing pain during delivery. I would just quickly trying to give you an idea of how it goes back home by taking a bit of the elements from the presentations. So you technically like get, I was taking down some notes so I can complete from what we do here. Talking about IV medications, we spoke about fentanyl and all the infusions that can be used. The problem in Cameroon generally is the availability of these drugs. You wouldn't find fentanyl easily available in many towns because it's one of the drugs which I think the system, anticipating that people may get into abuse, the distribution of drugs like fentanyl and many opiates is limited to the centers where you have specialists who can manage. And just to paint a picture of the 25 million Cameroonians we have, there are not more than 60 trained anesthetists. So you understand it's really a very difficult situation to manage. You have only about 60 persons on the whole, on the national territory who are trained in the management of pain during delivery, like placing epidurals and all of that. So it already shows you that there's clearly going to be a handicap on that part. Yeah, I think Dr. Ojong just included 28 retirees. That's a bit much, but the 60 actually includes about 20 persons who are retired. So technically we have 40 people who are actively working, and it makes the work even more difficult. Also, the IV medications, we avoid them because generally there's not always that monitoring for women and the children. So you wouldn't start a fentanyl infusion if you don't know how you would monitor the kid's heart rate or other things as such. And we tend to exclusively go towards regional techniques. So there's the epidural, and we also do a lot of end of labor spinals because we know spinal has a short duration. And so we start with the epidurals, and towards the end, we do end of labor spinal. So usually what we'll do is, if we can't catch up a woman when she's about 3-4 centimeters, if she comes in late, which is usually the case, and she's about 9-10 dilatation, we'll give them an end of labor spinal analgesia, this time not spinal anesthesia too. And just give some degree of comfort and relaxation when they're doing the last phase. And generally that's how we catch up, because there is also the problem of cost, which I will speak of at the end. Spouses in labor room, technically, I'm sure you understand it's difficult. Our labor rooms are not designed to have spouses in them. You have about 10, 20 women sitting. You don't expect 10, 20 men in the room. It's difficult, but in my hospital, we have some sort of a VIP delivery room where women who get epidurals have their spouse there and people who can sit by them and help them. But gradually, we'll probably get to that stage, but technically, it's difficult to do that. One of the ways we use, talking about making anesthesia accessible, which I'm just trying to follow the different points of the presentation, is the implementation of third trimester anesthesia pre-evaluation. Usually women come for their third trimester gynecology consult. So we are trying at our level to implement that consultation with an anesthetist at the third trimester, so that you don't only get to have the gynecologist's point of view, but the anesthetist also tells you, look, these are the options you have, this is how it works, these are the complications that you may have, because that is the information many women don't have. And you may hear it from the gynecologist, yeah, this is what can be done, but when you get it from the person who's supposed to have the thing done for you, like the technical difficulties, in how much time you need to come to the hospital, when I will put the epidural, when you're going to act, how you feel, what the complications you may have. I think that's one of the things that lack in most centers, and we are struggling on our part to start something of that sort. Talking about nitrous oxide, it's very interesting. It's very good for the first stages where you want to gain time before setting up your epidural. But obviously the problem in Cameroon is cost. It's really expensive. When you look at the Cameroonian setting, it's really very expensive setting up nitrous in hospitals. Very few centers. I know of just 2 centers in the whole of Cameroon, because I have checked and I have worked in one of them. There's only one center that has nitrous oxide really available, and it's not it's an eye center where they do like eye surgery and all of that. So those are some of the challenges we have. Coming to complications, because those are the things most women complain about, because they, like most people, read on the internet, headaches, back issues, and all of that, it sort of discourages them from getting to do an epidural, even if they know someone who can do it. So generally, talking about post-dural puncture headaches, you would find many women who undergo spinals in Cameroon developing these headaches because, unfortunately, we get all these, I'll call it this rejected needles, because now it's legally wrong to use a needle which is bigger than 25 gauge, a 25 gauge needle for a spinal. It's legally wrong. So imagine all those countries that have produced all the bigger needles and all the large ones, the 22 gauge, the 20 gauge. So you find like large stocks of the bigger needles being sent forward here. And in some centers, people still use it because they have no choice. They have no other access. This is what they could get. And as such, you still find people using 22 gauge, the large black 22 gauge needles to do spinals. And I mean, it's horrible because most of them get referred to us because, oh, this person had a spinal, their headache. So we do a lot of blood patches. And in my own practice, what I like tell my residents is you should not be scared of doing a blood patch because, yeah, it's invasive, but at our own level, it's the closest thing you have to getting that comfort, because I'm sure Elvis probably said it, but it is the recovery from post-dural puncture headaches is spectacular after a blood patch. Like immediately you slide it in, the patient like looks at you like this guy is a magician or something, But of course, we can't continue using large needles, and it's important for us to let people know that, look, we need to start using the proper equipment, reason for which we are currently in the Cameroonian Society of Anesthesia trying to fight hard to advocate for proper equipment in anesthesia, because those are the kind of, it's one of the specialties that require a lot of equipment in order to make your statement as such. So lastly,
permit me to just interject at this point. You mentioned that there's a Cameroon Association of Anesthetists. So I think this is a nice opportunity for both associations to probably liaise, maybe after the town hall at the level of the parking lot, to look at potential avenues where work can be done together in terms of maybe sharing of equipment and knowledge and experiences that could benefit both associations. And maybe just to also follow up with some of the points you've made. How much does it cost on average for a Cameroonian woman to get anesthesia as regional anesthesia during labor and delivery in Cameroon?
Yeah, thanks a lot. Technically, the last point of cost, that's the point I kept for the end, because I know that is the misconception many Cameroonian women have about how expensive an epidural will be. So generally, when you do a vox pop, and I've done that before, like gone to women, I don't know, how much do you think an epidural costs? I know 250,000, 300,000 CFA. Nah, it's not that expensive. I would try to give you a breakdown of the costs from a Cameroonian perspective. Now, generally, you need to see an anesthetist. Let's factor that in. If you're seeing an anesthetist in private, you may pay about 15,000, but most of the anesthetists who do the epidurals work in government hospitals, and you don't pay more than 5,000 CFA to see a specialist. So that is already 1 point off. Secondly, when you factor in the cost of the equipment, an epidural, like the epidural catheter set costs about, when bought in bulk, I'm talking about like when we, the anesthetists, because we are obviously trying to get them for hospitals who don't really believe in getting equipment. Remember, there's a big challenge on equipment. But buying a set of 10 epidural catheters, one set comes at about 10, 15,000 francs, which I think is still affordable when you consider the average Cameroonian. But obviously not everyone can afford to get an epidural catheter. A vial of local anesthetic bupivacaine, because for the period of using bupivacaine for a period of about 6-7 hours, which is what you probably need on average for an epidural. One vial is about 3,000 CFA. That's 7,000 francs CFA, right? If you add this up, we have not even reached 25,000 francs CFA in terms of what you would need for an epidural, because you just need the epidural set and you're good to go. Now, the other things that the final cost which you'll be given in a public hospital to have an epidural sits at around 50,000-60,000 CFA, because you have to pay for the expertise, and the rest goes into equipment, which I think is affordable for quite a good proportion of the population, but not everyone as yet. but we can do better. We can drop that price. It's when you go into private clinics where sometimes the prices go as high as 100,000 and 150,000, depending on the kind of bed you sit on, the kind of room where you find yourself, you know, and yeah. So if the question is asked to me, is it expensive? I would say it's not expensive, but it's just that people don't have the right information about that. I personally do epidurals in private, and honestly, I've never really had to go to the point of asking for 150,000 CFA, because at some point I realized I'm one of the few people know I do epidurals. So the question generally is, why would you put heavy costs on something which should generally be accessible to everyone? So I think it's a question of people getting the wrong information about epidurals and not knowing that there are people who can do these epidurals for them.
Thank you so much, Dr. Zikonta. Dr. Ojo, now Dr. Zikonta just mentioned that, you know, at the cost of about 50,000 francs, maybe he hopes that quite a handful of women coming to deliver can afford those services. What has been your experience as a practicing obstetrician?
Thanks for giving me the floor, Alison. Good evening to everyone in the town hall. I am grateful to Aroke and Joseka. Truly edifying presentations. And I'm happy I saw Dr. Mbaku in the hall. I think the residents are preparing for their exams. I hope he took notes on obstetric analgesia. It will be really, really, really helpful. Thank you, guys. Beginning with Alison's question, I was really a little shocked when Dr. Zikonta said that it is just 25,000 francs. I was about to get angry. Then I remembered that, oh, okay, it's true. He hasn't been in the periphery like some of us have been. His experience is curtailed to a university teaching hospital, and it is very risky to assume that the women who come to Hôpital Gynéco-Obstétrique in Yaoundé are representative of the average Cameroonian woman. It's clear that they are not, because the reality of the average Cameroonian woman is that 50 to 60% still cannot afford 6,000 francs for a normal delivery. The reality is that 40 to 50% still cannot afford 40,000 francs for a cesarean section. And that's an incomplete cesarean section. So when on top of that, you want to give them a bonus which they don't need, which is pain control, and you say it's only 25,000 francs, I mean, it can be real trouble. Now, I will just throw in a comment, question, let's just think about it, and taking from my experience as an obstetrician. You know, if you put obstetric analgesia in every hospital in Cameroon now and made it free, I doubt you will have 5% of women who have obstetric analgesia. That's a risky statement, but I know what I'm talking about. Remember that labor and delivery are not an independent or isolated event. They are the hallmark of a whole journey, which is pregnancy. And prior to getting to labor and delivery, these women should have had some degree of antenatal care. Thank God, Aroke and Joseka mentioned it. And the overall goal of antenatal care right now is give these women a positive pregnancy experience. That's what we've been talking about over the last 5 to 6 years. And by positive pregnancy experience, we are saying that they have person-centered care, which is respectful of their physical and sociocultural integrity. It's very important. Once you factor in the sociocultural integrity of a woman, then pain ceases its clinical only significance. Pain takes on a cultural look. Pain takes on an anthropological face. And I can tell you that how different cultures interpret pain play a significant role on how women approach labor and on what happens in labor. I have patients who come to me who are postpartum depressed because they delivered by cesarean section. And the way their anthropology is factored, they are meant to believe like in not pushing that baby, they failed. To you and me, it makes no sense clinically speaking, but to this woman, She's living in an evidence which is not only clinical, but which is anthropological, which is religious, which is, so there's all these things that come into play. And we want to give her a positive pregnancy experience, which means not just good mother and child outcome, but acceptance of who she is and of what she has been through. Which is why I think that, I am for obstetric analgesia. Let's be clear about it. I think I've been on Dr. Raymond's neck back home. I have a patient we need to manage. We need to offer painless labor. I am one of those who advocates for painless labor. But I think the first step towards ensuring effective implementation of obstetric analgesia, beyond health system modifications, beyond addressing issues of cost, addressing issues of technical know-how, it is important we start addressing anthropological realities. And just a teaser to step out. Yeah. If you are in a delivery room in Cameroon, when a woman puts to birth and the midwives take the baby out, the first person they ask for is not où est le père de l'enfant. They don't ask for the father. They say où est la grand-mère. The first person they put the baby's hands, they give the baby to is a grandmother or an aunt. They'll hardly give it to a male figure. What does that teach us? Different anthropological factors are playing. So that is just my little experience. Thank you once again, guys.
That is a great approach, and that's one of the beauty of the town hall. People come in with perspectives that, you know, just make everything holistic. And that was just the question I was about to ask Raymond, that do you think that, you know, access to painless delivery is some kind of authentic service for women, or is it like a service that a woman desires when she's going to the hospital to give birth? Asking this question because of the cultural aspect. There are some women who believe that when they do experience that pain, and that is what makes them believe that they actually had, you know, a positive experience of a childbirth. So if you want to place it on a scale of 10, how will you say is a perception? What will you say is a perception of a woman who really needs, you know, painless delivery? Does she consider that it is a privilege to her because she can afford, or does she think it is some necessity that she needs?
Well, good question. Exactly, because we are currently carrying out a study on the perceptions of Cameroonian women on epidurals, because it's part of a study aimed at boosting the capacity of our hospital, the Yaoundé Gynaecological and Pediatric Hospital, on managing women for epidural, like giving them women epidurals for delivery. And I would say it won't be such a straightforward answer, because so far with what we've been able to get, many women consider it some ostentatious, like a bonus, an advantage to their delivery. And, you know, they see it as, look, it's the people who can afford who do epidurals. It's not for me. It's for those who, you know, it's for those who do it. Like they say, these people do it they watch women on TV. They can do it because they can afford it. They don't see it as something that they really need to have to go through. But you have a tiny proportion of women who are like, yes, they know it's good, they know it works, but they don't know how to go about it. And they are sometimes not given the proper information about where they can get it, who they can see, what hospitals can offer them in that light. And obviously you have the large proportion of women, which is a very big proportion. And unfortunately, it's sad to say, among those people, you even have a lot of medical staff who think that epidurals for delivery are not necessary, and they are more of a danger than an advantage. This is speaking from experience, from colleagues who have openly told me, unlike gynecologists, like colleagues like Ojong Sama, who have literally told me, look, this patient needs this, and he has actually referred a lot of patients to me. But there are a lot of other gynecologists who would technically tell their patients, you know what, you don't need an epidural, you can manage, you know, the pain of delivery without that. So it's a bit of a mixture of these three different populations in what we see in Cameroonian women today.
Thanks, Dr. Zikonte.
I just wanted to follow up on that. Is there like the use or not use of epidural analgesia, does that predict postpartum depression?
Actually,
that exists between the use of epidural and postpartum depression that we are seeing on the rise?
Maybe I can jump on that. So one of the systematic reviews that I showed earlier that I looked at did not show any correlation. But I mean, I would think, just from my own personal opinion and thinking about how traumatic the birthing experience can be, you would think it would contribute at least, to postpartum depression. But actually, research does not support that there's any strong correlation.
Okay.
Yeah,
I think. Please go ahead.
To add to the aspect of the postpartum depression, I think Dr. Ojong said something here which really should point towards the answer. The experience of pregnancy and delivery should not be delivery should not be taken up as the key points of a pregnancy. The pregnancy ends with the delivery, of course, but it's a whole experience that the woman has. So the depression that she would express, obviously, I don't think it necessarily only binds to what her experiences she had with the delivery. I think it's perfectly possible for a woman to get into depression because of the way she had probably no support during the whole pregnancy, even if she had an epidural at the end anyway. So I think it's a complex thing, which obviously would require more studies in the African context to understand what causes what and what are the impacts of different things on depression.
Just a woman who is expecting a male child and who has 6 female children and is expecting a chop share and finally ends up with another girl, you can have that as a confounding if you judge it to be caused by anesthesia. Meanwhile, there are other cultural factors. I get you, Raymond. Thank you so much.
Thanks for those interventions. So maybe for the interest of time, we're just going to take 3 last questions. We have a comment in the chat from Norbert. Norbert mentioned about the public health implications of, or the public health side of having anesthesia in our Cameroonian setting. Maybe, I don't know if Dr. Aroke and Dr. Njozeka would want to comment on that, but as you think about what you could say with regards to the public health implications of pain management during labor, I'm wondering if there's room for task shifting. Looking that we have just 60 people who are really qualified anesthetists within the country, and some of them are already retired. Is there room maybe to train interested group of people who are maybe not that qualified, maybe in specific aspects of this pain management for specific settings? Over to you, Dr. Aroke and Dr. Njozeka.
Yeah, Dr. Weah, that would be an interesting take on it. And I think one of the key issues when we think about the public health interest would be to look at it from overall, how can we improve the system, right? And I think, yes, training, physicians to provide anesthesia is, for instance, here in the US, is quite different from training nurses to provide anesthesia. So that may be one way to conceptually start thinking about who do we prepare and how do we prepare people for these roles. I know there has been a recent uptick in Cameroon from talking to some of the nurses about community workers, right? Again, you have in analgesia, epidurals are the gold standard, right? That is what, if you want absolutely no pain, that is great. However, we have a gradation of things that we can do. Granted, opioids are supposed to be controlled substances, which I'm a strong advocate for controlling access to opioids, especially the very potent opioids. That would be great. But as you go down the chain, right, you get now to other less potent drugs like Nubane, right, which are agonists, antagonists, things like that. Those are less potent drugs, which will provide some level of analgesia. You have non-opioids, which will provide some level of analgesia. So I think there may be room for training of not just, anesthesia providers, but even nurses to be able to give some of the non-opioid analgesics to at least take care of some of the basic pain. If you have a pain of 10 and I can bring it down to a 7, it's better than staying at a 10, right? So that would be one thing. And I would like to equally comment on, again, if you look at most of the non-pharmacological interventions, it requires, a change in the way we set up the delivery rooms, which I think most of us here, I will bet that of the 26 people currently locked down, there is somebody somewhere thinking about opening a clinic, or somebody is talking to you about opening a clinic. Maybe that is where we should equally be thinking of, okay, should we want to go replicate the same thing of having so many women delivering babies in one room, or is it time for us to move that conversation to the next level of having private delivery rooms where there is some privacy and you can have room for somebody to be there to provide that support that is very needed? So I think for me, I think it's about engaging in that forward thinking. How can we make tomorrow better than it is today? And finally, addressing Dr. Samuel's point on the sociocultural aspect, which is, again, I tie that to health literacy, right? A lot of that is really linked to how much do we really know? I always make a joke of it that back home, when you take a tablet, the mom next to you says, hey, what's that medication for? Can I have one, please, right? So health literacy, I think, is a major, bigger problem where this sits within that. This sits within the context of health literacy, which we have to slowly start addressing as providers.
Thank you very much, Doc. I'm going to call on Dr. Carlson Asangwa. His hand has been up, and he's currently, this is his area, so he would want to share his thoughts as well. Dr. Carlson, you're muted.
Hi all, and good evening to you guys. Shalom from Jerusalem, Israel. And it's quite interesting to participate in this. And kudos to the great presentations from the two doctors from the US and interventions from Dr. Ojong and also Dr. Raymond. I just want to say, like, this is actually one of my areas of interest. I'm actually into that. Like, I'm a fourth-year resident in anesthesiology. Like, I want to share a little bit of the experience in my institution. For the women who come in labor, we have 12 private rooms for the women in labor. But each and every time there's a woman in a particular room, if she needs, and if the midwife calls you for pain management, and you simply get into the room, you present the different options to the lady. That there's the different options we have here will be the nitrox, which the midwives can administer to the patients. Secondly, we also have the epidural, of course. And thirdly, we have remifentanil. Like I said, epidural, like I'll not belabor that. It's the best and the most optimal. And I want to stress on the fact of the using an epidural, because more and more we're having ladies with difficult airways, like obese ladies. And we don't want, in the case of an emergency cesarean section, to want to start manipulating the airway of this lady. He could die and obviously lose the baby. So if you have the ideal is have a working epidural in these ladies, quick, early on time, to manage their labor through. And now when there's a contraindication for an epidural, what next? We use remifentanil, and I just wrote a comment in the group. Remifentanil it's one of the most potent opioids. It's very short acting. It's zero other kinetics. It's taken out of the system through by hysteresis. So what happens is we simply prepare a drip. It's still an IV PCA. You prepare a drip, put it in a syringe pump, and you tell the lady to push each and every time she feels pain. So it works and wears off within 2 minutes, which means you can use it, stop it at any moment in time. It wears off within 2 to 5 minutes. This no matter how long it can be used. So these are for what can be used in the periphery. I think remifentanil, if it's controlled, if it's well controlled, you can use, that is an option which you can use in the periphery. You simply need to just prepare it, make a lockout dose. These syringe pumps can be in such a way that the lady cannot get an overdose, and she can use it at any time and as long as she wants. And immediately you stop the remifentanil drip, it wears off within 2 to 5 minutes, which means there's no risk of it, of the baby the fetus being born with it. And one other option is now with also acupuncture. Some ladies can also go for acupuncture and massage, which is a technique which can be done for the midwives. The midwives can can actually do these techniques on the ladies in the rooms. Like obviously they tell you massage, taking the deep breaths and all of this. These are little techniques which can be done in our milieu, but epidural, I would say is overrated to have it for somebody in Ako, for somebody in Anyadra or Kikakilaki. Sorry for maybe calling these places, maybe I don't want to offend anybody in the group or for the presentation, maybe that's your village or the rest, but I'm simply saying we can't have these in all of those places because epidural needs a continuum of practice. If you get an epidural and you have let's say a hematoma, I need to go and operate this hematoma. You need a neurosurgeon. You don't have this neurosurgeon in I don't know where in Matom or some other. Yeah. So exactly. So I think for me, what I propose, like as a solution of this, is continuous discussion of such, training of more specialists and deploying them to the different regions, and also training like these syringe pumps. These syringe pumps are not so expensive. They are not expensive. You can have a syringe pump at 50,000 francs or 150,000 francs. And you prepare this really fentanyl syringes, and you just prepare the nurses to the midwife to administer to do it. But although you need to have someone who is experienced in airway management in this institution.
Okay, thank you, Doc. I wish I can have some acupuncture and massage when my time comes to go and push at La Quintini. I'm really praying God for that, you know. And when you call Kilaki, it hits home for some of us. So thank you for your comments and your contributions, Doc. I see Lobga Galiga's hand is up. I think that's probably going to be the last comments we're going to take for this session. And after that, all other contributions, questions, suggestions, and networking is going to happen in the parking lot. So Lobga Galiga, please, can you go ahead with your question or your contribution?
Thank you so much. I'll just try to keep it brief. I had 3 questions, but Dr. Ojong actually took one of them out about the cultural issues regarding pain management. It seems to be some form of pride in the African settings. I say so because I'm just coming from the Gambia and I worked in the rural area, and it's more of pride for a woman to go through that labor, and she's seen among her community like a real woman. The next thing I was going to ask, I'm going more in the direction of the non-pharmacological approaches. I don't know, the anesthesists are here. I would just like to ask them, first thing is there any role of screaming when the woman is in labor? Does screaming or shouting, does it really play any role? Are there any studies out there to actually assess if they feel better? Why? Because I remember my time as a house officer, the debate was to let them scream or not to scream. Some are of the opinion that just let them scream, let them let it out. But some believe that screaming actually wears them away and then it reduces bearing down. But I don't know if there's been any studies to just assess if screaming or shouting during labor actually helps. And then the next thing I'm going to ask is, looking at the trend that is happening, especially in this COVID era, where we've seen alternative medicine and herbal things coming up. I say this, my premise is about 2 weeks ago, I was in Akonolinga and I was in the farm there, and I saw this gentleman come and take a bark of a tree to give a woman who was pregnant. I think it was to help her with either labor or with producing milk. I don't know if they've ever seen any studies that show there are any alternative methods, especially herbal ways that help women in, you know, reducing pain during labor, because it's only a matter of time before we start seeing women trusting that more than the conventional ways because of what they believe needles are. I'll say so because in the Gambia, some tribes believe that when you use a needle or a syringe, for example, it gives the person yellow fever. Don't ask me where that came from, but that's the belief they have. So I want to know if they've come across any studies that are actually, you know, propagating those kind of things. Are those things that we want to look at? Do they have any positive effects, any adverse effects that they know? And thanks again for the good presentation.
Okay. All right. Well, let me just kind of address your question regarding the screaming. I mean, there's really no research that I've come across that supports or does not support screaming. But I know one thing for sure, when I, you know, reading from LAMACE and other websites that actually cover a lot about OB, you know, obstetrics and pain management. screaming is not abnormal. It does happen, but the implication on the clinical side is that usually when the patient gets to that point where they're screaming at the top of their voice, it's sort of a panic button. That usually tells you that the patient has reached that stage where they cannot tolerate the pain of labor. So either the pain is just worse, or essentially it's at that point where something needs to be done different, be it pharmacologic or non-pharmacologic. And so, that's sort of like, the implications for us as anesthesia providers and on the clinical side. But to your point of, does it make the patient feel better? Does it not? I mean, you see, it's one of those areas that I tell people, do not judge the dynamics of a relationship during the labor and delivery process. Because I've seen ladies curse their husband, they would normally not do that, but just because of the pain that they're experiencing from labor. And so it's one of those things that, I tell people, go with a non-judgmental attitude, focus on what you have at hand, which is making the lady as comfortable as much as you can. Get as much information from her in terms of how much pain is she having, and give her some reassurance, and provide emotional support, to help her get through that phase. So, I mean, not really sure if that answers your question, but just, a little bit of information to help with that.
Yeah, just to add to that, I think there is definite room for that in terms of the emotional aspect, right? Again, like we said, pain is sensory and emotional. And we all know that when something hurts, when you cry, you feel better, right? We always say if you keep the emotions in without an outlet, it's not good. So, and if you draw from some of the literature that we see in chronic pain management, we see that, things like catastrophizing, right? And there's emotional aspect, or the mourning that is associated with pain leads to better pain relief, right? Those who use those coping mechanisms, because that's a woman's own way of coping with the pain, they tend to feel better. So if you inhibit her from using whatever coping mechanism that she has developed at that acute stage, it's more likely to be detrimental than helpful.
Thank you for those contributions. I think at this point we need to start rounding up. It has been an exciting discussion. Elvis, what do you think?
It has been a very interesting conversation, and as usual, I just do some summaries before you close it up. Alison, we talked about pain management today. We had Dr. Venasius and Dr. Edwin, who were our experts today. We heard from them that pain has a sensory and an emotional component, and the first definition was that pain is an unpleasant sensory and emotional experience associated with or representing that associated with actual or potential tissue damage. And we also heard that it's always a personal experience. We were focusing more on labor, and we said labor is an emotional experience with physiological and psychological mechanisms involved, and that is always different for each woman who enters into the labor room, and it can be different for each labor as well. And the question was, why should we worry? If we do not believe that a woman is in pain, then we will not do anything. So the first thing is believing that they are in pain so we can be able to do something. And pain is a big deal, as we heard. Many illnesses are manifested by pain or through pain. So which means if there is no pain, then we will die because we will miss the signal from most of those illnesses. So when you have increased maternal stress, this can also lead to increased oxygen consumption, and unrelieved pain may lead to long-standing psychological and emotional problems. We heard about feelings of guilt, anger, and loss of self-esteem because of past experience of pain, or severe depression, anxiety, obsessive compulsive behavior, or even sexual problem resulting from pain experienced during childbirth. We also heard that the pain of childbirth is arguably one of the most severe pain a woman can experience in an entire lifetime. And this was confirmed by an online poll in which a woman said, please, I don't want to think about that day anymore. I cried like a child and I would not like to take it anymore. You see, these were testimonies of women expressing their personal experience of pain. And we said the presence of the spouse in the labor room can help to just abate the feeling of pain by the woman. But this has been challenged by the current infrastructure in our country, where we have more than 5 women in the same labor room, and for confidentiality's sake, spouses are not able to enter into this setting to give this needed emotional support. And we saw some of the challenges of optimal pain management in Cameroon, and one that was highlighted were cultural factors. And we agree that our society is a very patriarchal society where men seek to address their issue first. And we said if pain was being felt by men, they would have sorted a solution faster than the situation now. And we also talked about health literacy and said there should be discussion about the option that women have for pain management during antenatal care. And this was confirmed by Ojong, who said that it is an entire journey from pregnancy that ends with delivery. And so we can't only isolate the outcome, which is the delivery itself, but look at what happens through that journey of pregnancy. We also look at the need to have fetal and maternal monitors, because we cannot talk about anesthesia, epidural anesthesia, without thinking about all the equipment that we need to monitor the fetus and the mothers in this time of labor. We also talk about providers' bias. Most providers enter into this environment with bias, believing with their personal belief about labor, wanting to place a judgment whether this pain is because she's having her first baby, or because she's young, or because she's come from a particular culture. These biases can actually influence the way we handle issues of pain. We've looked at spinal and epidural anesthesia, and even said some of the only contraindication for to epidural is the woman's acceptance or rejection. So we want to be able to see also the challenges of administering this kind of procedure, considering the fact that in Cameroon, there are only 60 trained anesthesists, of whom 20 are retired, leaving us with a number of 40. For a population of 25 million, you can imagine how desperate our country needs trained anesthesists to be able to help women to have access to pain management during delivery. It's difficult to have spouses present in the labor room, as we heard before, and this is an eye-opener to all those who are planning to open clinics in Cameroon, that you could think about redesigning health infrastructure to provide this kind of atmosphere where women can enter into the labor experience with some degree of privacy and confidentiality with support system that they need. And we also talk about the fact that people still use 22 gauge needles to administer spinal anesthesia. And this is because they use 22 because these are abandoned needles that other countries don't need. But it is criminal because we heard from experts, I think it was Raymond, that the standard is 25 gauge needle that is supposed to be used. And these are issues about availability, and this has to do with health economics, how much of our health system budget allocation actually goes for pain management and to take care of these issues. Is this an area of interest to our Ministry of Public Health? Is pain management an area of interest, and what is being done to make this possible? First of all, Alison, this is a very interesting conversation because it brings together two organizations, the Association of Anesthesists in the United States of America, as well as the Cameroon Association of Anesthesists. And I think this collaboration is going to be that which can lead to some better outcome of pain management for pregnant women in Cameroon. It was a great deal, and this is what I was able to gather. Over to you, Alison.
Thank you so much, Elvis. I truly appreciate. And yes, we can't talk about this without mentioning that our obstetricians are at the back and they're just nodding and like, okay, so this is like an area where you probably have different sectors truly collaborating for to be able to attain an optimal experience for any woman who's going through labor. Oh, my mom picking them, my papa, them, my brothers on the platform here and those watching online. I also not own year. So when you get belly woman or your sister who is pregnant, even if she cannot have access to the medications, that emotional support and being there is very important. Even if you don't enter that labor room for now because of the way things are designed, make sure that you are a formidable husband. Make sure that you provide her with an amazing support system just to help her go through that journey. I'm now going to call on our chairman to give the vote of thanks so that we can close the 29th session of the town hall.
Wow. I just want to say wow, because it was a big school for me too. I learned a lot. It's always kind of medicine, you get to not really understand what others do. And I told Dr. Aroke the other day, we are part of the problem in healthcare. a lot of both our patients, our family members feel because we're physicians, we know everything. And we could be part of the problem because there are certain things we don't even know and we don't get to educate ourselves about. So I think this platform acts as a way of also educating each and every healthcare worker who is part of the platform. Knowledge is the first thing in order to make change. And the more we get informed about different specialties, about different things that are available, especially what options are available for healthcare workers, it actually gives us a better platform to advocate for these things. I just want to go back and reflect about what we are talking about back home in Cameroon. In Cameroon, we have approximately about functional 40 anesthesists that are existing, including Raymond and also Carlson, who is in training. But as Raymond knows, we have about 180 district hospitals, and I can assure you none of them have an anesthetist, none. I can say this boldly, none. 180 district hospitals, none has an anesthetist. We have 10 regional hospitals. Some regions have 2 hospitals. Let me put it to about 20 regional hospitals because the Southwest has 2, some regions have 2. And in those regions, less than half of them, about 10 of them do not have, including major hospitals in major areas that do not have one anesthetist that stays there and wants to even live there because of the conditions. I'll take for the Northwest region, there is no anesthetist there. At the moment that we're speaking now, you have about, let's say, 1,800 health centers. That's where women deliver. If we think about what they call minimum package of activities, that's where women deliver in Cameroon. Women don't deliver in l'Hôpital Général, which I know very well. Women don't deliver in gyneco-obstetric, which I know very well. Women deliver in health centers. That is where the thing happens. Do we even have appropriately trained midwives to even take care of these women? Cameroon stopped training midwives in 1992. My mom was a midwife, and I know that very well. Cameroon resumed training midwives, I think that was in 2008. So there was a whole gap of almost 25 years where there were no midwife trained in Cameroon. And this is part of the problem. We have also a lot of private facilities and everyone, about 5,000 in Cameroon. We have a need, and I think this topic has really come to strengthen the fact that we need to have these discussions. There are many more discussions we'll have in the town hall. I'm very grateful. I'm humbled by both Aroke and Dr. Ngong, who came in here, Venasius, to help us understand this topic and get a discussion. The town hall belongs to the people. It belongs to all Cameroonians. You have ownership of this town hall. It's a platform that we can use to valorize other associations that exist. So if you know of any association that want to come in, let us know what they do. Let us get their experts to talk to the Cameroonian people. We're welcome. And I'm inviting Raymond and Carlson to start thinking about telling us about how anesthesia works in general in Cameroon. I think I'm going to come for you soon. So you guys should be ready for it. It's been a while since we met. Since I last saw you guys in med school, we have not really had a good chat. So I'm coming back for you guys. And I'm honored to have you guys as my juniors and my strongest ones, which I can look up to now. So I'm coming for you. So Elvis, I want to tell you, I'm very grateful. I have some seniors here, some juniors, a lot of people I've not met in a while. And I just want to thank the presenters for the wonderful job. And please stay back. We ask difficult questions at the end of the town hall, actually. This is just the tip of the iceberg. There is some little discussion that could go on for 1 hour where people get to say what's really in their mind. A lot of people can be political in Cameroon. They don't want to be video talking about political issues. So thank you all. And it was a pleasure, really. I think next week, next 2 weeks, we may be talking about the heart. And Dr. Clarence is here. I've not reached out to him. He's a cardiothoracic surgeon, and he's going to either in the next 2 weeks, or I'll follow up with him and we'll go from there. So Alison, thank you. Elvis, thank you. And also want to thank Brian for always being there. Thanks, guys.
Hey, thank you, Doug. I think on that note, we are officially going to close the 29th edition of the Cameroon Town Hall. And to all our participants, thank you for being patient with us and for staying this long. We know we went above time. You are amazing. Dr. Aroke and Dr. Ngong, you see, home is calling, you have work to do. So thank you for your time. Thank you for all the amazing work. And have a beautiful rest of the weekend to everybody.